afternoon. This is Darcy Gaden recording audio PowerPoint for the gastrointestinal system. We just have to have some humor, so I thought this was a good place to start. We have several functions of our digestive and gastrointestinal system, but primarily we think of digestion, absorption, and elimination. So it begins when we put food in our mouth or food particles, and that's the very first step where we have digestive enzymes and secretions that are mixing with the ingested food. And of course, absorption into the bloodstream of all of the nutrients is very important. The majority of this is happening in the small intestine. And then of course, elimination of any of the undigested and unabsorbed foodstuffs and other waste products. So we start with digestion and the end result is elimination. Understanding the anatomy of the GI system is very important. We're basically going to be going through all of the various conditions, starting with the mouth and oral cavity all the way down to the rectum. And so there are a lot of different disease processes and abnormalities that can occur from along that path. And so we'll be going through all of those. We have about 25 feet of gastrointestinal tract from our oral cavity to the anus. This picture does a nice job. I think we understand that from our oral cavity, the esophagus connects to the stomach. And so in this picture, you see it starting with the stomach. The very first portion of the small intestine is the duodenum. The middle section of the small intestine is the jejunum. And then the last part of the small intestine is the ileum. And then we move into the large intestine and we have the ascending, transverse, and descending colon, and then the sigmoid colon, and then the rectum. So we'll be talking about many conditions and where they are most likely to occur. So it is important that you understand the anatomy and the structures so that you can kind of get your mind to what it is that we are talking about. There's about 20 feet of small intestine and 5 feet of large intestine. The main function of the small intestine is absorption of the nutrients. And then absorption of water is primarily occurring in the large bowel. So water absorption in the large bowel and nutrient absorption in the small bowel. This picture is intended primarily to show you the different blood flow to our gastrointestinal tract. So the aorta and the abdominal aorta will then branch off and supply our GI system. You'll see the superior and inferior mesenteric artery and vein are integral part of how we are getting blood flow to our GI organs. As far as cardiac output, total cardiac output to the GI tract is approximately 20%. So we have what's called the hepatic portal circuit. I mentioned that the aorta provides blood to the stomach and small intestines loaded with nutrients from the gastric and mesenteric arteries. And then the blood is drained from these organs into the portal vein. So all of our GI tract organs, once they have received the oxygen and nutrients, will drain into the portal vein, and then that portal vein to the liver, and the liver will process that and then send it back to the inferior vena cava. So the GI tract again receives blood from the arteries that originate along that thoracic and abdominal aorta, so primarily your gastric artery and that superior and inferior mesenteric system. And then the blood that's drained from the organs via the portal vein, it's nutrient rich, carried to the liver, and then the GI tract, then the liver will get it back to the inferior vena cava. The other thing is just to understand that the GI tract is innervated by both the sympathetic and parasympathetic nervous system, but we are most readily aware that the parasympathetic nervous system stimulation is what will respond to the GI tract. Functions of the stomach are listed. It is the second step of the digestive process. Food typically will be in your stomach anywhere from 30 minutes to a couple hours. Secretion of gastrin, pepsin, and hydrochloric acid are key because those enzymes are what's going to help in destruction of any ingested bacteria, going to help to break down the food particles into a more absorbable content. And so all of that is happening in the stomach before it would move on to that first portion of the small intestine. Another function of the stomach is it secretes intrinsic factor, and this is an ingredient that is essential for absorption of vitamin B12. So if you have somebody that's had a gastrectomy, if their stomach has been removed for cancer, or if they've had weight loss surgery where they've had like a Roux-en-Y where most of the stomach is bypassed, they will most likely require vitamin B12 replacement for life. Again, the stomach can store the food and fluids. It'll be gradually released into the small intestine. We don't want it to be dumped quickly. And so again, 30 minutes to several hours. And then the very terminal part of the stomach is the pylorus, and that pylorus sphincter is responsible for that outlet. If you hear of somebody that has narrowing, they have a pyloric sphincter stenosis, that can cause a lot of problems. They can become very nauseated and have projectile vomiting. So when we talk about pyloric stenosis with infants, that is what they have, that narrowing in that area. The primary function of the small intestine is to absorb the majority of nutrients. It is composed, like I mentioned, the duodenum is the first part, jejunum, and then the ileum. Also, right in that first portion of the duodenum is where we access the pancreatic and bile duct system, and so that is where those enzymes will come into play. They will be released and enter at the duodenal bulb and start to do their process of breaking down carbohydrates, fat, etc. Our large intestine will absorb electrolytes and water. It does hold any of the undigested food for a bowel movement. We know that bacteria is a major component of our intestinal tract, so that does assist in completing breakdown of the fecal material. As far as the fecal material, it is normally approximately 75% fluid and 25% solid. Obviously that can vary from different conditions, and we'll be talking about some of that. And again, typically brown. We'll talk about what the discolorations of bowel movements can mean when we get to each condition that it may affect. Again, you can see in this nice picture the ascending, transverse, descending, and then the sigmoid, colon, and rectum. As always, getting an accurate health history is very, very important because there are so many different organs in the GI tract. We don't want to just ask them if they've had any GI history. We want to make sure we ask them specific questions. Have you had ulcers? Do you have any gastrointestinal conditions such as Crohn's disease, ulcerative colitis, diverticulosis? As far as surgical history, have they had their appendix out? So you kind of get used to some of at least giving them some ideas. Do they have reflux disease, which is common? Again, previous surgeries, other abdominal surgeries, which would be impact potential future risk of, say, bowel obstructions from adhesions from that surgery. We for sure want a current list of their past and current medications. We'll ask in particular if they are taking aspirin or NSAIDs. We know that nonsteroidal anti-inflammatory drugs significantly increase a patient's risk of GI bleeding, so we'll want to know that. On their medication list, I also want to know if they're taking any laxatives or stool softeners, if they have had a history of constipation. As far as the nutritional assessment, have they had a change in their appetite? Have they had a weight loss of greater than 10 pounds in a month? Are they having difficulty swallowing or dysphagia? Have they had nausea and vomiting? We typically, if they're coming in with GI symptoms, will have them recall approximately 24 hours of what they've had to eat, if they've had any changes in medications or different things for food. to kind of figure things out, because maybe it's a food allergy also. Tobacco and alcohol use, will get more to the significance, especially with liver disease, with alcohol use, and again, their normal bowel pattern. We want to know if they're having a bowel movement daily or what their normal baseline is, so that we can stem all of our assessments around that baseline. As far as pain goes, we want to know all of the specifics that you know from getting a full pain assessment, but again, in particular, their location and how they describe it is very, very important. We'll be showing you a slide here in a second of all the different anatomical organs and where they sit, and so knowing the location, for example, if they're complaining of right upper quadrant pain, we might think it might be more liver related. Right lower quadrant is just classic for appendicitis. So knowing the locations of organs is important to understand what it is that they're telling us about their pain location. And then indigestion. A lot of people may have reflux disease. They may have some discomfort after eating. So some of that may be normal. Some of it may be actually a disease process. But we'll want to ask very specific questions about how long it's been happening. Does it happen only when they eat certain foods, or is it kind of all of the time? And or do they have heartburn on an empty stomach? And we'll talk about what those things can mean once we get into the different diseases. So as I mentioned, this is just a review of the anatomy and physiology in which, or anatomy rather, of where the structures are contained within the abdominal area that you can help with your pain assessment. It is also important to note there is a fair amount of referred abdominal pain, so referred pain to other locations besides the abdomen. So this picture shows you the different locations. In particular, you'll see that right shoulder strap discomfort for perforated ulcers. We'll also expect to see some of that when they've had a laparoscopic procedure, as the air insufflated is rising before they're able to get rid of that and absorb it. A few other details related to the health history. We certainly want to find out if they're feeling bloated. We'll be assessing their abdomen for distension and asking them about flatulence, or if they're belching a lot. Again, it might be difficult initially to know if somebody's distended or not, or what their baseline is, especially when you're just newly meeting them. So it's perfectly fine to ask them if this seems normal for them, or if this is different. Same with if it's soft or firm. Sometimes some patients' bellies can be just normally and naturally a little bit more on the firm side, and so we want to ask them about that. As far as nausea and vomiting, vomiting up blood, we know that term to be hematemesis, and 50% of the time you will see hematemesis with upper GI bleeding, and definitely more common with gastric ulcer bleeds. So certainly the upper GI tract would make sense that there's going to be more possibility of it coming out in the upper portion versus coming out in the stool. So 50% of the time GI bleeds will vomit. Certainly we can still see a lot of GI bleeding in the stool, but just anatomically, hopefully that makes sense. As far as the discoloration, bright red versus coffee ground, there are some significant differences there. Bright red is soon after hemorrhage and or more coming from the upper area. The other thing is the coffee ground is when blood has been retained in the stomach for a while. The coffee ground appearance is due to the action of those digestive enzymes on that blood. So we always think of coffee ground appearance, emesis, or if we place an NG tube and we have coffee ground appearance in the NG, that there is old blood somewhere. Changes in bowel habits. This is the #1 early indicator of colon cancer. Patients with colon cancer don't usually have a lot of symptoms that would cause them to go to the doctor, maybe have a little bit of fluctuation of diarrhea and constipation, and that may be the only change. They may not really recognize it as something serious until they're actually having weight loss and having more issues with stool inconsistencies or blood in the stool, or maybe an unknown cause for their anemia. All of a sudden a low hemoglobins they're losing without knowing it until they get their blood drawn, and many times for just something else or on a routine physical. Stool characteristics then, melena or tarry black. This is again typically Most common with duodenal ulcers. 70% of the time, if somebody's having an upper GI bleed, the stool characteristic will be melena, or what we know as that tarry black. Bright or dark red, this can be the lower GI tract or passing rapidly. Also, make sure that you're really understanding if it's actually blood in the stool or if it was just blood on the tissue paper, if they have hemorrhoids, or some rectal discomfort, or inflammation or trauma. It might be just some blood there versus actually coming from the lower GI tract. And also, getting back to that darker or blacker or tarry looking blood, or excuse me, stool, we want to make sure we know if they're on an iron supplementation, because iron supplements will definitely make the stool darker, and usually a little more firm, and sometimes a little bit more on the black color. So all of these things are important to take into consideration when we are assessing the stool characteristics. Depending on where you're working, they may use this Bristol stool scale and may have a more specific way that they want you to document the stool characteristics. So I've just put this on here for your reference. This is just showing you some of the common cause of lower gastrointestinal bleeding, and you can see kind of a lot at that lower end. The ulcerative colitis and that descending colon is a common area. Polyps, colon cancers, the majority, at least 50 to 60% of colon cancers are the sigmoid colon or below, or towards the rectum. So at that bottom terminal end, rectal cancer, obviously hemorrhoids, and then you can see their diverticulosis or diverticulitis as well. So I know this can kind of seem gross to talk about stool and whatnot, but we do handle a lot of it. We need to understand how to chart it properly. You can see kind of the bright red. You can see the top left where it's a little more of that black color. Again, it's variable on what you're going to see as far as if it's more liquid or more formed. The top right, you can see how it's almost separated like oil, and that is unabsorbed fat. That's basically the fat that you're seeing in the stool. That's what it may look like. Obviously, there's other ways that we can see it as well, but the stool gets bulkier and whatnot. When you are assessing the abdomen, we know that we are going to inspect first, then we're going to listen and auscultate with our stethoscope in all 4 quadrants, and then we would palpate after that. Percussion would be the last, so it would be inspect, auscultate, palpate, percussion in that order. We don't typically do much for percussing as a baseline, as a regular thing for practitioners, but certainly if you're working like in a GI specialty, that might be applicable. By textbook, we are to listen to the right lower quadrant first. This is where the ileocecal valve is, and typically that will be the first place where bowel sounds will be heard. So again, if we are listening post-operatively, that right lower quadrant would be the first ordinarily to be waking up and to hear some sounds. And then just making sure that you're documenting properly. We always start with the right or left. So if we're saying right upper quadrant, it would be RUQ, not URQ. Not upper right quadrant, but right upper quadrant. So I just want to make sure you know that you're starting with the initial of the side, R or L, and then it would be upper or lower quadrant after that. Here's more of the summary for the physical assessment. Again, we're always going to be inspecting first and documenting if it's flat or distended. We're going to be auscultating in all 4 quadrants that you can see by technical assessment books how long you have to listen to be able to quantify in that area or that region. We typically are hearing what we're hearing more quickly than what it says on this slide, but certainly if I really truly wanted to document absent bowel sounds, I do need to listen for at least a couple minutes, not just 15-30 seconds and say it's absent. So again, just those are those terms just for reviewing for you. The other thing is to make sure that you're shutting the NG tube off. If they have suction, if they're hooked up to suction, that suction needs to be turned off while you are assessing. And besides the inspection and auscultation, then you'll do your palpation. Again, we will always be documenting whether it's soft or firm, and tender or non-tender. So flat or distended, tender, non-tender, and soft or firm would be always a given, in addition to documenting flatus and any other subjective complaints and things that they may have. I'm going to direct you to the muscle guarding rigidity masses. Again, it's really important also to notice if you have an abdomen that is showing that protective mechanism, so that guarding, that rigidity. So board-like rigid abdomen is a serious sign that would be indicative of potential peritonitis. So that is something that we don't mess around with. Typically in those patients that have that, they're already going septic, so they would likely have tachycardia and hypotension as well. So any rigid board-like abdomen, change in the pain and how they're describing it, along with looking at those vital signs, is something where we're concerned about an acute abdomen, whether they have peritonitis, have they ruptured an organ, have they ruptured their appendix, or what's going on. This question is asking about a 2-year-old client, so we will do number 4 first. We will listen when they are quiet and resting before, and even if we can sneak in while they're sleeping, or if parents are holding them, and have a warm stethoscope, that is ideal. We want to make sure that they do that, because as soon as they get irritated or cry, and especially like infants, it's very difficult to hear anything. The normal age-related changes that we would expect to see in the GI system then, a decrease in hydrochloric acid in the stomach. This can lead to decreased absorption of vitamin B12 and iron, and potentially increase the chance of bacteria that may have been ingested. They also will have more chance of constipation, decreased sensation to defecate, and just decreased amount of how their sphincters are working, difficult to expel that stool. They can become constipated and impacted more regularly. They're also, probably not drinking as much water. Their dietary stuff might not be as good. They might be on lots of different medications that have side effects of constipation. So there's lots of things that we look at with elderly with regard to that. Decreased lipase and decreased fat absorption. So they typically aren't going to tolerate fatty meals as well. Decreased drug metabolism by the liver is huge. They do have more chance of toxic accumulation of drugs that they may take, especially the ones that are very specific as far as liver metabolism, analgesics, anesthetics, barbiturates, any of those surgery-related medications, and then acetaminophen. You probably remember the connection with acetaminophen and your liver, and so elderly people can hold on to those longer. So we have to really think about that cumulative effect. And then they definitely will have increased reflux and heartburn. So a lot of GERD, a lot of undiagnosed GERD, and just heartburn in general as they produce more hydrochloric acid. Blood tests that may be applicable, complete blood count or CBC. This is where we're going to see our hemoglobin, hematocrit, red blood cells, and white blood cells. So that is very commonly ordered for lots of different GI conditions. If we're wanting to know if there's inflammation going on, well, that white count is going to be elevated. Infection, that white count will be elevated. And then certainly that drop in hemoglobin, hematocrit for any bleeding that might be happening internally. Complete metabolic panel, this is your sodium, potassium, calcium, phosphorus, magnesium. We know all of those key electrolytes. You lose a lot of them in the GI tract, so GI loss is a very common cause of low potassium and low sodium. We talked about that in fluid and electrolytes as far as if somebody's on an NG suction, they are likely going to be low on potassium. The doctors will replace the potassium to their mainline bag before they hopefully get low. Prothrombin time, we'll talk about the bleeding times. It's really important to have a working liver in order for your bleeding times to be good. The liver is responsible for production of a lot of our clotting factors. So if the liver is not working, we could expect an elevation in the prothrombin time, which means they have thinner blood, increased risk of bleeding, decreased clotting ability. So sometimes patients will go in and have really weird coagulation labs, and the first thing that they're going to think about is the liver, because the liver is the main site for protein synthesis and production of clotting factors. And then the next two, CEA and CA19 -9, there are different cancer markers that we can get via the blood. The CA19-9 is sensitive to colorectal and pancreatic cancer, so those could be, if they are suspecting, they could draw those. And then liver function tests, we will go over in detail in the liver, so I'm not really going to talk about them now, but in particular, we want to know what their albumin level is, which is that, portion of protein, ammonia, or NH3. In patients that aren't that have liver disease, they're holding on to or retaining the ammonia. And then amylase and lipase, also very important, especially when we get to looking at, say, pancreatitis. And then serum cholesterol and triglyceride certainly can be helpful just in general with other conditions of the GI tract, especially if you're talking about like gallbladder disease or other things like that. As far as stool specimens, you can see listed the different types of stool tests that we can do. Stool cultures are helpful because they can identify bacteria or viral. In particular, we'll get stool cultures if they are suspecting Clostridium difficile. So that's one that you'll see more regularly in the hospital. Occult blood is definitely by far the most common stool specimen or that stool test, and that's just measuring for that blood that is not visible to the eye. So there's recommendations for this for screening for colon cancer every year, basically after the age of 50 or starting sooner if they have family risk factors, immediate first-degree relatives. So this can also help evaluate for causes of unexplained anemia, or at least rule that out. Now the fecal occult blood test, they may call it that. They might say it that way, otherwise guaiac or hemoccult. Either way, the doctors may order it under a different name, but they all are basically the same thing. So you just have to recognize them as that's what they are testing. We can only send one stool in a 24-hour period, so sometimes they'll order hemoccult ×2 or ×3, and so if they're in the hospital that long, we'll keep sending one per day down to the lab. Fecal fat, they can measure this and they can see how much fat is in the stool over 24 hours. Typically, if we are not reabsorbing and having more of that fat excreted in the stool, it will be more of a bulky and greasy, like that picture that I showed you where that was at separation, and typically a more of a foul odor to it as well. Clostridium difficile, then, this is a bacteria released that causes necrosis of the bowel epithelium. And again, with Clostridium difficile or C. diff, a couple key things is to know that you can't use the alcohol-based foam, so everybody has to wash with soap and water. It is a spore, C. diff, so it must be brushed off with friction, and that's why you need to do soap and water and that friction motion to make sure that your hands are clean. For C. diff, we want to make sure that, before we suspect C. diff, if we see diarrhea and loose stools, we don't want to assume that everybody, has C. diff. So we want to make sure that they haven't taken laxatives in the last 48 hours. And we really want to know that they've had loose liquid stools, usually greater than 3 in a 24-hour period, plus if it has more of that strong odor, and we have reason to suspect, then certainly we would want to try to get an order for testing for C. diff. And a lot of facilities have a standard protocol now if a patient's having more than 3 loose liquid stools in 24 hours, and if they haven't taken any laxatives in 48 hours, then we already have an order and we don't have to call on it. We just use the protocol. So make sure it seems appropriate, though. Use your judgment. You do have to look at the whole picture to really see if you really think they have C. diff or not. And then we know that we have to put them in contact precautions, enteric precautions. And so if we are sending out a sample, we would put them in that. And then if it comes back negative, then certainly we can take them off. And then for C. diff, they will be treated with vancomycin is the best practice now for that. So they will be on an antibiotic specific for that. Now, as far as what stools can't be contaminated or mixed with urine, because of course sometimes this can be difficult as they're both, coming kind of one right after another or at the same time. So typically stool cultures we don't want mixed or contaminated with urine, because then we don't know if we're culturing out the urine or the stool. So hopefully that would make sense. It would not matter for occult blood as much, but definitely for stool cultures, they prefer them not to be mixed. So this slide has some great information on C. diff, and again, if you're not familiar with it, it is something that we have to be very aware of and familiar with how it's going to be handled. You can even see kind of the coloration of the stool, liquid stool in that test tube, because it does typically have a very classic color, smell, and it's usually mostly liquid. Again, contact precautions, but then enteric, because we also have to use soap and water. Otherwise, it's just the usual contact precaution stuff. This is just going over if we are doing an occult blood test and we're educating patients about that, say at the clinic, that they need to know that for approximately 3 days before the test, they really are asked to avoid aspirin, NSAIDs, vitamin C, a lot of red meats, horseradish, broccoli, turnips. There's kind of those lists of things that could potentially cause a false positive. Research indicates that iron does not cause a false positive, so iron wouldn't be an issue. And again, we wouldn't typically do the test if they have hemorrhoidal bleeding going on. We would want to wait till we know that they didn't have any bleeding from other, sources. Radiology or imaging testing is very important for most of your abdominal diseases and making a definitive diagnosis. Abdominal ultrasound, of course, is your least invasive or one of your least invasive that is, quick. It's 15 to 30 minutes. They're just going to do that ultrasound and visualize using sound waves. Very helpful for appendicitis, cholelithiasis. Again, we can't see behind the bony prominences, so it's not as good as like a CT or an MRI, but it certainly can be helpful. It's much more cost effective. Initially, they might be able to get what they need just off of an ultrasound or just a regular flat and upright x-ray. Typically, with any of the tests, you want to make sure you understand what the nurse's responsibility is for teaching, and then what the nurse's responsibility would be for preparing, anything before and after that is needing to be done. So in this case, they typically would like them NPO for approximately 8 hours before doing an abdominal ultrasound, and if they're having one specific for the gallbladder, well then they will definitely want them to be having a fat-free diet or meal for 12 to 24 hours prior. So for regular x-rays, you can see they can do an abdominal x-ray, which we just call a flat and upright. It's just a 2-view. There's no prep required. Certainly they'll have any jewelry, belts and stuff off. They'll have a hospital gown on. But this is really helpful to review masses, tumors, strictures, obstructions. CT scan, again, is going to be just better because it's a cross-sectional view, but you're still looking at all the same organs via x-ray. Typically NPO for a minimum of 4 hours prior to a CT scan, whereas an abdominal x-ray, you can just do it right away. But again, better imaging with the CT scan. CT scan, they can do with or without contrast, but typically they want to do it with contrast because it's going to be better view. And they can do it with oral or IV contrast, so they may have to drink some oral contrast ahead of time. The x-ray department is great. They'll come up, they'll tell you, they'll label the bottles of what they need to drink and by what time, and then what time their test is at. So our job is to stay on track with that and or communicate to them if we are not on track. If the patient is not able to drink and they're having vomiting or whatever, we would need to communicate that to radiology so that they can decide if they're going to do something different, if they're going to reschedule the time or delay it a little bit, and get that all figured out. Again, educate the client, especially if we are giving IV contrast, that they can expect to feel just a short-lived but warm, flushed feeling, or have a metallic taste when that contrast is being injected into their IV. Because we are using contrast, we need to make sure that if they're allergic to iodine, shellfish, or contrast dye that they know of, and those would be, contraindications for using contrast. Also remember that contrast dye is nephrotoxic, so it's really important to know the kidney function. If they do have somebody with kidney impairment and they're doing a CT scan, typically they will order that BUN and creatinine, or creatinine is the main thing they're looking at before and after. They might also give some extra fluids before and after just to kind of help flush things through and make sure all of that contrast is getting out of the system. And then lastly, because CT scan is nephrotoxic, CT dye, we have to remember to hold the metformin 24 to 48 hours, usually about 2 days before and 2 days after, that they will hold that metformin after any test that is performed with contrast dye. And then the MRI, the magnetic resonant imaging, gosh, my tongue is tied here today, but that will supplement ultrasound and CT, but again, that's the most expensive, so they're not going to just jump right into an MRI unless they feel like that would be sufficient, and sometimes they'll do that, especially if they can't do a CT scan with contrast, then maybe they will opt for that MRI. So upper GI series is also called barium swallow or gastrographin. And so with this, we are using contrast medium. So again, have to assess for allergies to shellfish or iodine. It is very quick. We're using imaging at the same time as we're using this contrast medium. Basically, the difference between barium and gastrographin is barium is not water soluble, whereas gastrographin is. So barium basically will turn to cement if it's not excreted. So one of the big things with if they are doing a barium swallow, or we'll be getting to next a barium enema, we need to make sure they're drinking lots of fluid in order to excrete that barium and to get it out. Now what we will see is like a milky white or like a chalk colored clay colored chalky white to their BM, and that's always a good sign if they've had contrast, because then we know that they are excreting that in the stool. That's what we would want in the first 24 to 72 hours after that. We know that that is all coming out. Gastrographin is water soluble, so that there isn't any problem with that. If they weren't to get rid of it all right away, it's just going to reabsorb itself and it's water soluble. The only thing with the disadvantage with gastrographin is there's less visualization compared to barium, so that's why they still do use barium a lot more than gastrographin, but I just wanted to explain the differences so that you are aware. We're viewing the upper GI tract with an upper series or a barium swallow, so you'll see the esophagus, stomach, and then that first part of the duodenum is what they're looking at, so they can see tumors, ulcerations, varices, and any structural abnormalities such as hernias, all in that location. Again, they will be initially pre-procedure NPO after midnight. The doctor may prescribe a laxative prep, but typically not a huge deal as far as preps go. No smoking or medications the day of the test, and then the biggest thing is increasing fluids to excrete that barium after the procedure. GI series, upper GI series will be contraindicated if they're thinking somebody has a bowel obstruction or they're concerned about a gastric perforation, and hopefully that would make sense. We don't want to put any chemical or ingredient down if it's not going to be able to go through, if it's obstructed, and then certainly if there's a perforation, likewise, we wouldn't want anything in that area. The only difference with the lower GI series, or otherwise called barium enema, is that they're just looking at the lower area, so the colon all the way to the appendix. So the large bowel primarily is visualized, looking for polyps, ulcers, tumors. Again, Crohn's disease, which is most common in the distal ileum, and they could see that. Ulcerative colitis is usually in the large bowel. So again, the biggest thing here is contraindicated. If we think somebody has active inflammatory disease that we might perforate, it's going to be the same for colonoscopies and endoscopies. We wouldn't do that with active disease where we might perforate with the scope. Now this is just an x-ray, but they still had the barium, so it can be irritating, so it would still be not done if they have active known disease. Clear liquids 24 hours prior, they will be NPO after midnight. They typically like them to have low residue for a couple days and then just clear liquid so that they can have better visualization. Typically will be a small bowel prep the night before, so drink in some mag citrate or Gatorade prep, phosphosoda, or go lightly. Those are the names that you will become familiar with as potential laxative or bowel preps for both this lower GI series, but then also for the colonoscopies as well. Again, increasing fluids after the test because we want them to excrete that barium. So I've added a slide just for client education post-barium study, so you can use this for any of the either the upper or the lower GI series where they are having barium, and just making sure that we get them drinking and making sure that we are watching for that chalky white stool so we know that things are being excreted. For our patient teaching for a colonoscopy, we'll explain to them that they're going to do direct visualization with a scope into, from the anus to the cecum. So they'll basically be looking at all of the large colon, detecting any tumors, any polyps, inflammation. This is when they can see basically everything. So they can see any of the diverticuli or ulcerative colitis and what the characteristics of that mucosa looks like. It is a cancer screening tool that is recommended once every 10 years after the age of 50, and then they will have a flex sigmoidoscopy once every 5 years. So basically every 5 years they will have a scoping. It's just that the colonoscopy is the full scope all the way from the rectum all the way up to through and up to the cecum. So the ascending, transverse, descending, all of that is being viewed. The patient lays on the left side lying, which is called Sims position for colonoscopy, flex sigmoid, and the endoscopy. So that's the same positioning for all of those procedures. As far as the type of sedation, they just go under conscious sedation. So it is a combination of Versed, which is an amnesic agent, and fentanyl for some pain. And those are the two combination medications that they'll be taking. They need to be in an area where they have ACLS certified RNs caring for them, and obviously the physician that is also certified with that if there were any emergencies. They have all the emergency equipment there. They're on a monitor, a heart monitor during this as well. Now, ahead of time, there will be certain significant teaching for the patient, and if we are doing the prep on the floor before they go down, we as nurses will be making sure all of this is happening. They will be on clear liquids for 24 hours. No red, orange, or purple jello or liquid so that it doesn't look like blood or discolor what that will look like in there. NPO for 4 to 6 hours prior to the procedure. Most of our patients are just NPO after midnight and scheduled in the morning, but it would be a minimum of 4 to 6 if they were doing it more emergently. Stopping aspirin and antiplatelets, any anticoagulants several days prior, usually ideally 5 to 7 days prior, they'd want to stop any of those anticoagulants. They will require a complete bowel prep. They need to be 100% clear, so we should have total liquid basically coming out of the bowel, no blood, or excuse me, no tan tinge or nothing. I mean, it's actually totally clear. So when they mean clear, and they're really particular about that. Obviously, we can't have a bunch of stool retained in that bowel and then they can't visualize, through the scope. All they do is see stool, and then it's a waste of time, money, and risk for that patient. So the preps will be the Miralax or Gatorade prep, Go Lightly, Phosphosoda, or Mag Citrate. Again, it sort of depends on the physician and facility, what they kind of have been using or what they prefer. There will be Phosphosoda is the only one that you have to be aware because it does contain phosphorus, would not be a good choice for somebody with renal failure because they are high in phosphorus and retaining phosphorus with chronic kidney disease. Other than that, it kind of just depends on what the facilities are using. Post-procedure, the most important thing is to monitor for bleeding and or signs and symptoms of colon perforation. That would be the risk of this procedure. While it is low to perforate, it is possible. Now, if they have colon perforation, they will basically go into shock. It'll look like septic shock, so we'll see a drop in their blood pressure, elevation in their heart rate, restlessness, and they might have more pain and abdominal distension. So that can develop over time as well, because sometimes they can have just a very small micro perforation, just a really, really tiny perf, where it may take a couple days before a patient actually becomes sick or septic. So this is something that we certainly watch for immediately after the procedure, but we also want to teach our patients and families to continue to watch for any of those things, or developing of a temp would also be, especially if it's developing later, and that would only happen if it was a really small perforation. But remember, there's all that bacteria in our bowel, so if we perforate any portion of the bowel or any of those organs, we have bacteria in the peritoneum where it's not supposed to be. Here's a nice picture showing you where the scope will enter and how far it goes. So basically it goes through all of that large colon, and you can see the different things that they are looking for as they are scoping. They can take samples, biopsies, remove polyps while they are in there visualizing. And this is the left side lying Sims position and what this would look like using the scope and the camera there on the wall. So for a sigmoidoscopy, it's basically all of the same things as a colonoscopy, except it's less extensive, and they're only looking at the lower colon, the anus, the rectum, and the sigmoid colon. So they're still evaluating for the same things, polyps, tumors, etc. Again, this is the cancer screening tool that will be once every 5 years. This will alternate with the colonoscopy where they're doing the full thing. You'll have all the same complications as far as checking for perforation following a sigmoidoscopy. Really the only difference is the prep is much smaller. Clear liquid still for 24 hours, still the same, no red, orange, and grape or purple fluids, but they will have a more limited bowel prep, typically just a laxative the night before, and not as all-inclusive has the full bowel prep that they need for the colonoscopy, which makes sense if you think about where they're looking. And again, 60% of the colorectal cancers are detected by flex sigs, so a big portion is in that lower colon, and so that's why this is recommended every 5 years, but then the full is recommended every 10 years. I mean, certainly if a patient has high risk and direct family relatives, they might opt to do a full colonoscopy every 5 years, but that would be individualized and up to the physician. So the green section here on the slide is showing you where they are looking for the sigmoidoscopy, and then of course the yellow, the rest of the yellow would be what would be for a full colonoscopy. Here's the American Cancer Society recommendations that we've already talked about. Basically, after the age of 50, they want to do a fecal occult blood test once a year, and then again the sigmoid every 5 and the colonoscopy every 10. They might start this at age 40, especially if you have risk factors or direct family first-degree relatives that have had colon cancer, but they'll work with your physician, they'll work with their providers on individualizing that. It's really important to ask our patients, even if they're not in for anything related to bowel cancer, if they're having their routine screening, whether that's a mammogram, the colonoscopy, the sigmoidoscopy, if they've been smokers, have they had that CT scan that's recommended. I mean, we can really do a lot for our patients if we're thinking outside the box and thinking more for than like just what they're in the hospital for at that moment. The endoscopy, when we think of endoscopy or an EGD, that's a esophagogastroduodenoscopy. And if you break up all those words, we're looking at the esophagus, the gastric, the stomach, and then that first section of the duodenum. So that's what the direct visualization will be for somebody that's having an EGD. So again, it's going to be in an endoscopy suite area, same as the colonoscopies and the sigmoidoscopies. We are going to have our pre-procedure things that we're doing, NPO typically for 6 to 8 hours, might be 12 hours at some facilities. They will typically again be NPO after midnight. They will have that same conscious sedation, which is that combination of Versed and fentanyl that will cause sedation, amnesia, decrease anxiety, but they have short half-life, so they wake up really quickly and go home. They will use a local anesthetic spray to the back of the throat. In addition, they may use atropine, which is an anticholinergic medication that will decrease secretions, which is helpful. Glucagon may help relax the smooth muscles to pass the scope better. So there are some options as what they're going to use for medications before the procedure starts. Sims position is the same, that left side lying with the right leg bent. And as far as post-procedure, really looks very similar to that of a colonoscopy, because our main complication would be if we have perforated. So again, tachycardia, hypotension, running a fever, that rigid board-like abdomen or change in abdominal pain. Those would be signs of a abdomen that is what they call maybe hot, or that is impending sepsis, and so we really want to take note of that and call the doctor immediately. And then the only other thing different is because we have gone through the oral airway or oral cavity area, we want to make sure that they have a gag reflex and that we don't start giving them any liquids until we know they're swallowing good and they're good and awake. But there are no restrictions for time frame for eating afterwards. It just depends on, as long as they're feeling good and they can swallow, we certainly would encourage them to start on more liquids and softer foods first, but then they can resume as they tolerate it. So here's the visualization and where they anatomically where they are looking for the endoscopy, the esophagus, the stomach, and then that first section of the duodenum. The M2A capsule is basically where it's a camera and a pill. Very, very cool technology. This is basically where they swallow this. It passes through their digestive tract. It's getting all these thousands and thousands of recordings that are sent to a recorder. It has an 8-hour battery life, so views basically through the small intestine area. 8 hours after swallowing the capsule, the patient will return to the endoscopy, or maybe it's the next day depending on what the facility's routine is, but they will then go back and review the images and findings with the physician. The only thing they have to do is be clear liquids for the 24 hours prior, and then they're usually just NPO for maybe 8 to 10 hours prior. They shouldn't have any smoking for 24 hours, and then once they swallow that pill, they can actually resume their regular diet 4 hours after that test starts. So it's a really pretty easy basic prep. It provides a lot of information. It yields accuracy of diagnoses at 71%, so it's very, for the most part, quite accurate without having to be invasive. The only other thing is to teach the patient that they will pass this capsule, and so they will see a blinking light in the toilet. They don't have to do anything with that, but just to make sure that they are aware of that. The Bravo is also a really neat advancement in technology where we can measure and monitor the pH levels, and this is very helpful for chronic GERD and people that are having a lot of difficulty with that. It's a catheter-free pH system, so it's placed via an endoscopy, so they do have to go through the endoscopy and conscious sedation to place it. But it's a pH capsule and receiver. You see the capsule there, the picture of that green thing. You can see the capsule in the top picture, that little clear, looks like a little cassette. That it's about the size of a gel cap. That is going to be placed, and it basically attaches, has little prongs that attaches into the wall of the lower end of the esophagus. And so this will provide 48 hours of data, and the beauty of this, the advantage, is that they can get the data while they're doing their regular activities, regular diet and regular activities. When only we could do NG pH monitoring, it was restrictive because they have an NG down, they can't eat as normal, and it was just very bothersome to even have the NG placed for just that. So again, this is really helpful because they can see how their body is responding as far as acid production and all of that with food and with activities, etc. So this will also slough off and pass in the stool, so there's nothing that they don't have to go back for an endoscopy to have it removed. It's only that initial endoscopy to place it. So the Bravo itself, the technology is fairly reasonable, but it's like $3,000 to $4,000 to have an endoscopy to place it. So that's kind of where it's not like a first line. Insurance companies aren't excited about paying for this first if there's other things that we haven't tried yet. So it is definitely a very, very helpful option and very accurate. It's just that it's not necessarily the first thing that they can order. So 2 hours post-colonoscopy, it's asking which data warrants intervention by the nurse. The answer is 4. So we see that tachycardia and the blood pressure coming down. Now granted, we don't have a baseline assessment, but a heart rate of 104 and blood pressure more in the 90s over 50s we know is more on the low side. So we are wondering if we have signs and symptoms of shock or early signs and symptoms that might indicate a potential bowel perforation from that procedure. Again, that's the most important, the highest priority assessment post-colonoscopy, post-sigmoidoscopy, and post-EGD or endoscopy. So all of that, if you learn them all together, they have very similar assessments and pre-procedure things that we're doing for them. So as far as diarrhea and when we would actually say or call it that somebody has diarrhea, that really does depend on their baseline. Because someone with Crohn's disease, for example, is always going to have a higher frequency of bowel movements, and they typically tend to be mostly loose, liquid, and probably rarely formed, if ever formed. So again, with that, I just say that the book says, greater than 3 per day, and that's fine, but it's also the consistency, the amount, and kind of comparative to what the patients normally do at home. So any condition that can increase intestinal secretions or decrease absorption or alter motility will put somebody at risk for diarrhea. So irritable bowel, lactose intolerance, celiac disease, just any of those things could definitely, and we have medications, of course, that can impact. We know that antibiotics can cause, especially if they're on several or on them for a longer period of time, that they could get diarrhea as a side effect from their medication too. So symptoms vary from people to people. It's like, some get cramping and distension and not feeling well, and some don't really have that, but just have the urgency and have more of that, more volume and consistency change. Complications, of course, would be looking at fluid and electrolyte abnormalities, in particular watching for hypokalemia. We lose a lot of potassium in the GI route via GI losses, so watching for cardiac dysrhythmias. And if we're looking at hypokalemia, we'd be watching for that inverted T wave or the U wave if they had a telemetry monitor on. As far as treatment, we'll give them the antidiarrheal medications if that's appropriate. Lomotil, Imodium, you probably recognize those medications. Again, onset would be typically approximately about an hour for the orals to be absorbed. They will peak typically in 2 to 5 hours, and they can have up to a 10 to 12 hour duration. So we want patients to know that it's not going to work immediately in the first 10-15 minutes here, but we can get it going and hope that they will have some effects, within a few hours. One other thing with the antidiarrheal medications is that they can get a little drowsy, so I usually do talk to them about that. This slide is just reinforcing what we've already talked about in fluid and electrolytes and other areas prior to now. But if somebody has gastroenteritis with diarrhea, then of course we're concerned about dehydration. So just kind of going through that, we would want to avoid fluids that have high carbohydrate or low electrolyte value. Carbonated drinks are irritating. Fruit juices that are high in sugar aren't very helpful. Any of the coffee and caffeine or stimulants that would increase peristalsis, we'd want to hold off on that. The brat diet, you remember bananas, rice, applesauce, and toast. And again, this can be a nice transition diet. And then for elderly, remember their signs and symptoms of dehydration. They can have more of those atypical signs of dehydration or atypical signs that they can also get with infections of just confusion or irritability, restlessness, or just a change in their level of consciousness or what their normal baseline is. So we want to really watch for that as well. And of course, they can get really weak and dizzy quickly and have a higher risk for falls. Also higher risk for skin integrity impairment. They might already have very thin skin, so we want to protect their skin especially, and of course keep them safe, making sure they're not getting up alone. And with that urgency, sometimes they're just not being as careful and can trip on things, so they have to have a clear path and all of those fundamental things that I just wanted to remind you of. For pediatrics and infants, of course, they are very elderly and infants are highest risk or rate of dehydration and fluid volume deficit. So we also want to be watching for early signs and symptoms for them: tachycardia, low blood pressure. For the infants, the sunken fontanelles. We can also expect very dry or absent urine in the diapers. They might be crying and not have tears, so we know they're very low on volume if they don't have tears. And again, protecting their skin. We're used to using wipes with babies, but if they have a breakdown, even if they have just reddened skin, that alcohol-based wipe is not going to be good. That's going to hurt really bad for them. So we would probably want to just use warm cloths, warm water, and just gently be tapping to get them dry, and obviously the same with drying them. And again, that would be true for elderly that have sore bottoms. We have to be very mindful of what that would feel like when you're that sore and raw down there. Just another summary slide that hopefully is helpful to remind you of all the pediatric considerations for diarrhea. Again, you can see we've talked about most all of this already. You know, telling them or teaching parents of when to call the doctor for that age group is super important because they can dehydrate so quickly that they have to watch them closely. And, you know, if they've been sick for 24 hours and they're already, you know, they're 1 year or less, we're seeing these signs. And even then, if we don't have to wait 24 hours, but I'm just saying we're not going to wait days before these pediatric patients would be evaluated. Constipation is 5 times more frequent in the elderly, and that is no surprise. If we think of the many things that happen, just the decreased muscle tone, decreased GI motility and peristalsis, decreased sensation to defecate, what their diet may look like, maybe less fiber, less fluid, decreased activity and mobility that helps to stimulate peristalsis, and then all of the medications that they're on, and many of them that have side effects of constipation. So many reasons why our elderly population is at higher risk for constipation. Again, constipation will be defined by the patient's baseline as far as whether they are or are not constipated. Not every patient will have a bowel movement every day, and some people will have several a day. Some might only have one every 3-4 days. So we need to understand what that is before we would say that the patient is constipated. We also want to listen to them because they know when they're constipated. Typically, they know their body, and so even if they've had a bowel movement today but they're still feeling constipated, we want to listen to what they have to say. As far as other signs and symptoms, they might actually have notable distension, but not always. And again, they may typically, when we know they're constipated, if they have the very hard, dry, small stools, and if they really have to strain to get them out. So really important to hopefully prevent constipation in the first place, but then also to make sure we get them on the appropriate medications if they are experiencing constipation. Complications can occur, such as fecal impactions. If they've had chronic constipation, they can develop hemorrhoids and just that chronically inflamed bowel, which we call megacolon. And then also we are concerned about vasovagal response because if they are in the bathroom straining to have a bowel movement, they can drop their blood pressure and heart rate and get syncopal and basically near passing out or pass out. And so that is called a vasovagal response, and we would want to be aware of that and hopefully teach them, you know, to try not to do that when they're in the bathroom. Here's a review of the causes of constipation. Of course, hopefully when you think of medication categories, you think of opioids, we think of those pain medications, we think of iron supplementation, the anesthetics and tranquilizers that slow the bowel down for surgery. Many antidepressants will cause or can cause constipation as well, and then our anticholinergic medications. So those are some of the just major ones that we absolutely obviously are always looking for. Not that there can't be other medication categories, but those are really the top hitters. And again, other causes of constipation are listed there. Immobility, lifestyle, diet, if they have low fiber, low fluids, they're not exercising, those can all contribute to constipation as well. So I grew up on a farm, so I really can appreciate this box of hay that is the highest fiber cereal on the market, but just like to add a little bit of humor here and there. Teaching prevention of constipation, basically especially focusing on their diet, increasing residue, fiber, fluids, giving them a handout of high fiber foods, talking to them about adding bran and bread and wheat and things like that, those kind of grains that will add fiber in bulk. Obviously, vegetables and fruits also are high in fiber, and again, those whole grain products. So they have fiber-enriched cereals and things as well. So kind of find out their likes, dislikes, and figure out what food items might be appropriate for them to add in. Simply just adding water is super helpful as well. Establishing a bowel pattern, not holding it, those sorts of things are very helpful as well. If we think of our nursing home patients, you know, it's got to be tough when they, you know, they don't always get the help they need right away, and they have that urgency for a bowel movement or voiding, and then by the time somebody helps them, that's got passed. So that can be difficult. We got to try our best to get to them when they need us, and so that we can hopefully get that moment when they're feeling that urge. An exercise regimen would be helpful. Again, even if they're more chair-ridden or bed-ridden, can we teach them some leg exercises noises, and even all of that moving around in bed in range of motion can certainly be helpful. Abdominal toning is awesome because if we can have strong abdominal muscles, that really helps with the prevent constipation and the ability to actually have the bowel movements more readily. So even if they're sitting in a chair and can contract their abdominal muscles often and hold it and then release and do that several times a day. Leg to chest lifts, again, super helpful for that lower abdomen if they're able to. And then of course that normal positioning, if we can get them up to the commode, up to the bathroom, and not try to have a bowel movement on a bedpan, that can be very, very difficult for anybody. So it's really important for us to remember that positioning, gravity can do a lot for us as well. So you will want to make sure that you review these laxative medications better on your own. I have listed the separate categories of laxative, but I have found that most students don't really know all the differences between each category. So you can't just say it's a laxative because they all work and act a little bit differently. They all have differences as far as the time frame and the onset of action, and some that will be stimulants and some that, like the fecal softener like Colace, is just going to add water just to make the stool softer and easier to pass. It has nothing to do with being a stimulant. So I think it's really, really important that you yourself understand what they are, because we see all these medications, Metamucil, Milkamag, Miralax, and I know for myself even, I wasn't always sure of all the differences, but it's really helpful if we know them better, especially again focusing on onset of action so that we can teach our patients properly. We will begin by talking about diseases of the oral cavity. So this first slide is just an introduction on preventative health for the oral cavity, and most of it is very self-explanatory, but just wanted to have a summary slide of things that we can talk to our patients about, and in particular ask them if they're seeing the dentist regularly, and for sure making sure that we make note of if their dentures are ill-fitting or not. Again, there are some generalizations for care of patients with oral cavity problems, such as removing dentures if they have severe stomatitis or oral pain, making sure that we're taking care to do good oral hygiene after meals, mouth cares every 2 hours, mouth rinses, making sure if they are having issues or sores that we're using a soft bristle toothbrush. And again, if you have oral surgeries, there'll be warm saline rinses that are ordered for our patients. So we want to make sure we help with that. Typically, they will want them to avoid commercial mouthwashes that contain alcohol because, of course, that would burn. And then as far as food and nutrition, that will depend on how long they have to be clear liquid or soft. But for sure, non-acidic foods, wouldn't want to be having orange juice and things like that if they have had just oral sores in their mouth or have had a procedure of the oral cavity. This is a picture of oral thrush, so I'm not sure if anybody has seen oral candida or a yeast infection, but we see it often, maybe not always this bad, but on the tongue and inside the mouth. So you do need to really make sure it can be kind of inside the cheeks and be more patchy. So primarily, especially if a patient is taking antibiotics or undergoing chemotherapy, they are particularly susceptible to oral thrush. Before we continue on, I should also add for oral thrush that the treatment would be mycostatin or nystatin, swish and swallow. So many of you are probably familiar with that as well. So cancer of the oral cavity, it's less than 5% of all cancers. It is greater in men than women, 2 times more common in men, typically greater than age 50. Now, pretty good survival rates if caught early, 84% survival rate for 1 year, 59% for 5 years, and 48% for 10 years after diagnosis. So cancer of any part of the mouth or throat, risk factors, huge risk factors are going to be your alcohol and tobacco use, but then also sun and wind exposure, again, chewing tobacco. We think of the lips having a lot of exposure to the sun and wind, so it doesn't have to be just inside the mouth, but kind of in that outside area as well. So usually don't have early symptoms. That can be the problem in catching it early at times, but later on, once it's usually slower growing, so it may take a while to have more serious symptoms, but typically they will have had a painless lesion that won't heal. So definitely if you have something non-healing in the mouth or oral cavity, cavity that should be checked out. Could be an indurated ulcer, could be something that doesn't even look too bad. But we certainly wouldn't want to wait till blood tinged sputum or weight loss and dysphagia and difficulty swallowing, because those typically are going to be your later symptoms. Here I've just inserted a couple different pictures, and these are pretty bad, pretty obvious oral sores, but it can be even more mild than that. Certainly the treatment for oral cancers does depend on the location, extent, etc. But if they are having like a radical neck dissection, this will be removal of all of the cervical lymph nodes from the mandible to the clavicle and even into the sternocleidomastoid muscle and internal jugular vein. So this is a very intense surgery. Obviously there can be partial versions of this and maybe not as significant, not needing to remove as much tissue. But if they are having sort of a major neck oral cavity type surgery, we would want to provide all of the, of course, pertinent preoperative education, try to decrease their anxiety as much as possible, educate them on what to expect, assess what they have for support systems. Airway is always going to be number one. If we think about the area that we're doing surgery or any procedures on, they will be more comfortable in the high Fowler's position, as well as that will help with facilitating breathing and also increasing any of the lymphatic drainage after the procedure. Pain management, of course, will be a priority, as with any surgical patient. Wound care, they may or may not have a Jackson Pratt drain, so again, we'll want to be watching for output of that. They might even have, anywhere from 80 to 120 mils in that first 24 hours, but that should go down as the days progress. Nutrition is going to be a big deal. Typically, anybody undergoing major surgery of the oral cavity or neck is going to have and expect weight loss, but we'll want to try our best to keep nutrition intact. And mouth cares, of course, every 4 hours, oral cares, and more of high protein type shakes and things that we can help. And of course, monitoring the patient's weight and accurate INO would be important. Of course, promote coping and effective communication. There's a lot of body image due to the location, can affect speech. We typically would do ear temperatures, not oral, just because of the areas that we're working. And of course, maintain physical mobility, which would be important for any type of surgery to get them up moving with that. They also can do radiation to these types of areas of where surgeries are located in this region. So I know of patients that have had like tonsil cancer, where they've done radiation. And if that's the case, just one side effect, a couple side effects of radiation of this area, it really does do a number on the taste buds. If you think of all that radiation, it's killing those bad cells, but also all the healthy ones as well. The patients typically lose kind of all of their saliva, and so have really dry mouth. Taste and eating and food is just not as good anymore. And they potentially can have hearing loss if we think of radiation of that neck and towards that ear area too. So those are all things to consider with radiation therapy to the oral and neck area for cancer treatment. Here's a list of nursing diagnoses that would be appropriate. Of course, we're always going to look for that ineffective airway clearance and impaired gas exchange as our number one priority, since those have to do with airway and breathing. But we will also be paying attention to the mucous membranes, pain. Risk for infection is quite high in this location and region, just because it is in the same proximity if we're putting food, and is food particles getting caught in areas where it shouldn't. So that is something that will definitely, they'll have to do mouth rinses after eating and so on to make sure that we're not getting something caught. And then again, a lot of psychosocial teaching, body image, and things to have to deal with. Typically a lot of reconstructive surgery that might be planned for later as well. Cancer of the esophagus is very strongly associated with alcohol and tobacco use, and then also association with what we call Barrett's esophagus, which is a chronic GERD, that they've had, a more serious chronic GERD for multiple years, and they see extensive damage to the lower esophagus as far as the mucosa, and they call that Barrett's esophagus. So we do want to assess for those risk factors, alcohol and tobacco especially. It is 3 times greater in men, usually that 50 to 60 years of age, but I know I have taken care of younger people with cancer of the esophagus. Typically very poor prognosis. It has usually spread beneath the esophageal mucosa into the lymphatic system, unfortunately, by the time that they get diagnosed. Because there is typically not early signs and symptoms, there is a delay in seeking treatment of approximately 12 to 18 months via the research before somebody has gone in. So it's slow growing, but it has basically impacted multiple areas and spread into the lymphatics by the time that they are initially getting treated in many cases. So most common symptom for esophageal cancer, though, when they do have symptoms, is dysphagia. You talk to patients and they feel like there's a sensation in their throat when they swallow. They just kind of feel a lump every time they swallow. They have a lot of regurgitation of undigested food and hiccups, and then they talk about a real foul breath that they have noticed more commonly that they didn't really pay big attention to probably until they were having the actual dysphagia. So medical management certainly depends on the type and the extent and patient preference as far as how aggressive they want to be with this. Chemo and radiation will definitely usually be done if they want to try to reduce the size and extend their life some. Improving nutrition is a huge priority, of course, protein and calories, and then they possibly could have a more aggressive surgery and take that esophagus out. If it was all contained in that area, that could be a possibility. But again, then they're going to need a feeding tube placed for feeding the rest of their life. So the patients that I've taken care of have not wanted to have that type of quality of life, and so they haven't opted for that, and they've gone more for the chemo and radiation. So treatment is definitely variable by patient situation. So here are some pictures of what it could look like if they did take out the esophagus, where they could reconnect and how they can use the bowel and kind of create a new GI system. A hiatal hernia is a diaphragmatic weakness through which the portion of the stomach protrudes into the thoracic cavity. So if you make note of this picture and you see the diaphragm and then you see the esophagus and then you see the stomach below the diaphragm, with the herniation there is a weakness where that herniation basically slides up above the diaphragm and will produce symptoms similar to GERD and heartburn. So that opening in the diaphragm and through which the esophagus passes becomes enlarged, and part of that stomach moves into the lower portion of the thorax. So that's what we call a hiatal hernia. 50% of patients with hiatal hernias don't even really know they have one unless they were doing, some testing for it. So they typically are asymptomatic. But the other half of the patients will have heartburn, which we call pyrosis. Again, when the upper stomach stays above the diaphragm, the stomach acid is retained longer, and then they have that heartburn and that burning sensation in their just mid-epigastric area. Substernal burning, again, feeling of fullness. They may or may not have dysphagia or difficulty swallowing. They typically do have quite a bit of belching, and then they notice the symptoms are worse when they are reclining. Management of hernias sort of depends on the severity of the hiatal hernia. For sure, we would want to advocate for frequent small feeding, so not to add too much pressure that would then allow that weakened area for it to protrude above the diaphragm. So the stomach rather would stay below the diaphragm if there was less food and less pressure there. So frequent small feedings, not reclining 1 hour after eating. They may want to sleep with the head of the bed up 4 to 8 inches to prevent that hernia from sliding upward if they're laying supine just by gravity. So those, first 3 bullets are going to look very similar to what we would say to somebody with gastroesophageal reflux disease too. So you see a lot of similarities with treatment of hernias and reflux disease. Obviously here there is an anatomical weakness And if it's severe enough, they could do surgery, but you can see the percentage of patients that have surgery for this is not very high. So a Lapnesin we'll talk about for patients also that have GERD that is not being well managed by meds and diet. But this is where they wrap the stomach 360 degrees around that lower portion of the esophagus, and they just tighten that area, and then that prevents that herniation from happening. So because we are sticking more to the GI tract, we're not talking about all the other herniations, but I did want to just insert a few slides to let you know that there are several different types of hernias. I'm not sure if any of you have seen an inguinal hernia, which is right in the groin area. I know we've had patients with umbilical hernias where they have a large herniation in the stomach, so you can see the big protrusion, and that would be the herniation that you're seeing. So that lump or protrusion, and again, some are bigger than others, but some can be very, very noticeable, and once you do your assessment, you will see them. So again, depending on how much the hernia is bothering a patient or what their risk factors are for having surgery, they may or may not have surgery. But we know that we can use abdominal or scrotal support for the hernias to try to help keep it tight and kind of help it feel stable and kind of stay constricted, if you will. So the abdominal supports looks a lot like the lumbar corsets that you'll see for back injuries, or an abdominal binder. Maybe you've heard that, where if you have somebody that's very obese and they're worried about evisceration of a wound, that they might order that to just kind of keep everything tight when they're repositioning and getting up, etc. If they do have surgery, there's lots of different minimally invasive inguinal hernia repairs and other hernia type repairs. So again, we're not going through all of that, but there will be the possibility that you're caring for somebody who has a hernia or who has had surgical management for a hernia. If they have had a hernia repair and you are taking care of them post-surgically, there are just some standard teaching and priorities that we talk to them about, such as avoiding coughing, really rough, vigorous coughing. Again, we want them to do deep breathing exercises. We want them to use their incentive spirometry, but we don't want them to do that harsh coughing that can put strain on where they've had their repair. Early ambulation will be important, of course, to prevent blood clots. If they've had inguinal hernia repair, there'll be scrotal support that we'll use. We'll elevate the scrotum and apply ice packs to the site. Obviously, we'll apply ice packs to other sites of hernia repairs as well. As far as males, they'll want to stand to void, avoid straining or lifting. That reducing the lifting and lifting restrictions is really, really key to making sure that they don't hurt or injure the repair that has just been done, because if they take it too soon, if they go too fast, they could actually cause that herniation to happen again, and now they've just had surgery and now they've just basically ruined what they did during their surgery. So those are really, really important for us to stress, the lifting restrictions and the straining after they've had hernia surgery, even if they're feeling well. Gastroesophageal reflux disease, or GERD, is a very, very common GI diagnosis for many of our patients. Definitely increases as we age, increases with obesity as well. The chronic GERD is termed Barrett's esophagus, Barrett's esophagus, and can be a precancerous condition. Otherwise, GERD alone isn't necessarily causing cancer. It is certainly more of a just discomfort for patients because they're feeling that discomfort of the reflux of the stomach from the acid refluxing up into the lower esophagus. So causes of GERD: incompetent lower esophageal sphincter. So that sphincter is responsible for keeping it tight and only letting and minimizing the amount of that gastric acid coming back into the lower esophagus. So that is something that is the most common causes. So symptoms: frequent heartburn is the most common symptom. So your pyrosis, which is that burning sensation, or what patients will refer to as heartburn. Dysphagia, difficulty swallowing, may or may not have that. Regurgitation, that sour or bitter taste. Dyspepsia, which is that indigestion. And again, may mimic the symptoms of a heart attack. So when patients are complaining of heart attack, chest pain type symptoms, we always consider it cardiac until ruled out. And it may or may not be GERD, it may or may not be a heart attack, or it might be both. So it's really important that we look closely at the signs and symptoms and don't just, chalk it up to heartburn because they may be having a cardiac event. This is a list of things that lower the esophageal sphincter tone. So even just normal healthy individuals, we want to reduce or minimize the things that are on this list because we don't want to lower our healthy esophageal sphincter tone. Patients that have GERD that we know have a problem with lower esophageal sphincter tone, we definitely want to talk to them about these food items, about the medications, and just take a real good look at things that they can do to help their situation. Endoscopy is really one of the most important tests for patients with GERD if they're having lots of problems. But quite honestly, a patient report and just their history and their subjective and objective information when they're at the physician's office would usually be enough for them to start them on medications. They don't necessarily have to have a test done to definitively diagnose GERD. Certainly, if they're having issues, they're not having good management with medications, the best thing that they can do is go in with a scope and see what things look like. Take a biopsy, make sure that there's not any cancer or anything else, and then go from there. But I just want to clarify that they don't have to do any of these diagnostic tests to start somebody on medications, because they start older people on on anti-ulcer medications all the time without any testing per se. Again, there are other monitoring, 36-hour pH monitoring, which is typically with an NG tube. The Bravo that we talked about earlier, where 48 hours is recorded in that catheter-free system. They have that Bravo placed via endoscopy. Esophageal manometry, that measures the pressure in the lower esophageal sphincter, so that can be very helpful. And then bilirubin monitoring, or BiliTech, measures the bioreflex pattern. So there are many things that could be helpful, but again, none of these things necessarily would need to be done to be confident that the patient has GERD and confident as a healthcare provider to start them on the medications that would be the appropriate treatment. Because even if they do these tests, the treatment was typically the same. So I think most students and nurses would think that GERD management is pretty straightforward. We want to avoid situations that lower esophageal sphincter tone. So, stopping smoking, limiting or reducing or cutting out completely caffeine, alcohol, fatty foods, those things that were on the list. We would have a low-fat diet. Again, you see the avoiding caffeine, alcohol, tobacco, milk. Milk actually increases hydrochloric acid production, so that's why the milk is on there. Avoid eating or drinking 2 hours before bed, so we would never want to eat and then lie down, again, because of the gravity because of gravity, that would increase the risk of refluxing right after you have eaten. Maintaining a healthy weight is really helpful. That helps the lower esophageal sphincter tone as well. Increasing the head of the bed at night, especially if we're having more difficulties with it. As far as medications, we will be reviewing all of these very detailed in a bit, so I'm not going to go through them now. And then surgery, Lap-Nissen or Stretta. So Lap-Nissen is where, again, they wrap the gastric fundus around the sphincter of the esophagus. And so they tighten that area and improve that sphincter tone. And the Stretta is basically a thermal lesion procedure that I'll be showing you here in a second. So this is a picture of the Lap-Nissen fundoplication, and this is again where the fundus of the stomach is wrapped around that distal esophagus and sutured in, and then it tightens up that sphincter tone. So basically it's going to reduce the amount of reflux because we've tightened that all up. Now the one thing with this is that they usually cannot vomit anymore. I mean, and sometimes it can be too tight. It gets so tight that they even have difficulty passing food, like swallowing and getting it through how it's normally supposed to go. But it does really well for a lot of people, and it can help them greatly reduce the amount of medications they're on and help them be much more comfortable and free of heartburn type symptoms. But again, if they get sick, they typically can't vomit because they can't surpass that tight area that they have made. So this is a picture of the Stretta. The Stretta is used, it's minimally invasive and outpatient procedure. It uses a disposable flexible catheter with needle electrodes and a control module. These devices use a precise controlled radiofrequency energy to create these thermal lesions in the lower esophageal sphincter. The procedure is performed under sedation. The Stretta catheter is inserted in the patient's throat to the junction of the lower esophagus and the stomach. And again, the main thing that they're doing is creating these thermal lesions that will basically cause all of that tissue then to slough off and create its new healthy tissue. Gastritis is inflammation of the gastric or stomach mucosa. Patients can have acute gastritis or chronic gastritis. Many of you may have had acute gastritis before, and typically it's going to heal itself within a few days. Some of the causes of acute gastritis can be dietary indiscretion. We know that NSAIDs, those non-steroidal anti-inflammatory drugs, can cause gastritis, but they also can cause gastric and duodenal ulcers. Radiation therapy, H. pylori bacteria, of course smoking, alcohol, caffeine, those are all irritants to the stomach mucosa as well. So that gastric mucosa or stomach mucosa becomes edematous, inflamed, and secretes a scanty amount of the gastric juice containing increased mucus. So with that gastritis, again, typically have more of a rapid onset, especially with the acute gastritis, rapid onset of the epigastric pain and discomfort, and may have nausea, vomiting, heartburn, anorexia, and maybe vomiting blood potentially, but definitely not feeling like you really have a bad stomach ache. So it's important to know with gastritis that it isn't going deep. You see how it's just affecting the very top layer of the gastric mucosa. The mucosa is supposed to provide us a barrier to protect the stomach from HCl, and so if that gets damaged, you can see how that acid is getting deeper, or it's going to be impacting and causing you to feel more heartburn. But as you can see, it is not going into the submucosa or muscularis, and that's where we'll have pictures coming up here with ulcer disease where you'll see it going into those deeper layers. So with gastritis, it's just the gastric mucosa that's affected, and as a rule, patients will recover in about a day. Appetite might be down for 2 to 3 days, but the gastric mucosa repairs itself very quickly. Signs of gastritis are listed here. Again, abdominal discomfort, may have nausea, vomiting, anorexia, may have some hiccuping or heartburn, and may have what we call lassitude, which is just that weakness and exhaustion. May have a sour taste in your mouth, regurgitating some of that acid back up into your mouth. Once we are done going through peptic ulcer disease, which we're going to be getting to next, we will talk about all the medication categories. Again, pharmacological therapy for gastritis, GERD, peptic ulcer disease are all using the same class categories of medication, so I'm just going to wait till we're done talking about all of them before we cover all of the medications. This picture is just showing you where the gastric and duodenal ulcers will be. So gastric ulcers, you can see, are in the stomach, and then duodenal are typically right at that very first part of the duodenum, which we call the duodenal bulb. We will use the term peptic ulcer disease to talk about ulcers of both the duodenum and the gastric area. So if somebody has peptic ulcer disease, we will further figure out if they have a duodenal ulcer or if they have a gastric ulcer. Although treatment is virtually the same, some of their signs and symptoms might be different based on the area that their ulcer is at, and we will be talking about that. But either way, there is an ulcer or break in that mucosal lining, and it comes in contact with that gastric juice, and of course they will have pain as as a result of that. You can see some of the causes or etiologies. We always want to notice that the alcohol, smoking, caffeine, and excess milk, those are all risk factors for somebody for ulcer disease, and those are things that they can modify. The other big one is the chronic use of NSAIDs or steroids. So 4 times more chance of developing ulcers if patients are taking nonsteroidal anti-inflammatories such as ibuprofen using a lot of that, or steroids such as prednisone. I think it's important just to review the pathophysiology of peptic ulcer disease. So there is a disruption in the normal protective mechanism that keeps the gastric epithelial pH normal. And in particular, the second bullet is hopefully helping you make the association regarding NSAIDs and aspirin products. So prostaglandins increase resistance to acid. And so if you have substance that decrease prostaglandins, which NSAIDs and aspirin do, that then also decreases that gastric mucosal resistance. So that's the reason why NSAIDs are such a high risk for GI bleeding and for development of ulcers. 85% of ulcers for peptic ulcer disease are duodenal. 80%. I don't know if I said 80 or 85, but 80% are duodenal and 15% are gastric. So again, we will talk about the differences in both. You can see in this picture where the location is typically at for both of those. Gastric ulcers do increase a patient's risk of cancer, and the other thing with duodenal is they are more commonly associated with H. pylori bacteria. So those are a couple differences that you will notice as we talk more about them. For those of you who like the pictures, they have some great Creative Memories notebooks for the GI tract again. This picture does a really nice job of showing you the acute and chronic ulcer, showing you initially that erosion, or that what we would call gastritis initially, where we just have damaged mucosa, but that damaged mucosa isn't able to heal itself and act as a barrier, and so it goes deeper and deeper. So you can see those hollowed out areas of the acute ulcer and how deep those chronic ulcers can get and how difficult they can be to heal. When we get to our medications, we'll talk about medications that reduce acid production, which is important. We can see how much it would hurt if acid hits those areas because the mucosa is what protects it from the acid normally, and it's gone. But what about the protective coating agents like Carafate? You can see that medication is going to actually provide a protective coat over the top of that area, and that in combination with a medicine that decreases acid is very helpful. Just a couple more pictures to show you what that ulcer can look like, and of course the right side is an actual ulcer that you can see. The next couple slides will be comparing gastric ulcer versus duodenal ulcer. So you see the age and the equal by gender. We know that it's 15%. The things that I'd like to point out is you can see some of the risk factors again that are many of them the same for both. The most common complaint is more of like a dull, gnawing, burning, hunger-like pain in the epigastrium area. So that heartburn type complaint. Vomiting is more common with gastric ulcers, and again, if you think of the gastric ulcer being in the stomach, it's higher up anatomically, so vomiting, it'd be more likely for vomiting, for it to come upwards anatomically. Pain is going to be a half hour to 30 minutes, 30 minutes to 1 hour after eating. And again, because it is higher up, the pain onset is sooner than what you will see for the duodenal ulcer. There is no relief with food. It doesn't, well, let me get to the next thing. It says normal to decreased levels of acid production. So gastric ulcers don't have an increased amount of hydrochloric acid being produced. Therefore, no relief with food. Food typically, as you will see with patients with duodenal ulcers, will neutralize the acid because there's over activity of acid production with duodenal. So hopefully it makes sense with gastric. If we just have normal acid, food isn't going to help neutralize the pH. So that's why no relief with food. Pain, again, 30 minutes to an hour because it's higher up anatomically than a duodenal. And a hematoemesis is more common than the tarry stools, again, because of its location. So hopefully that makes sense. I do have underlined the differences for gastric ulcer, and so now on the next slide you'll see those same things underlined, and you can compare and contrast how they are different with duodenal. So duodenal ulcers are 80%, so they are much more common, definitely have more of an association with the H. pylori with duodenal, but you can still see many of the same potential risk factors. Again, same sorts of complaints, burning, cramping, same location, mid-epigastrium area, but now you see the pain is an hour and a half to 3 hours after meal because it takes longer to get to that duodenal ulcer area. So pain, and then pain also on an empty stomach about 1, 2 in the morning. Again, with this disease, with this type of ulcer, there is increased hydrochloric acid and increased peptic acid, so there is increased acid. With increased acid, if there is not food in the stomach and you have an empty stomach, there isn't food to neutralize. So that's why they can have pain on an empty stomach, and that's also why pain typically will relieve their symptoms. Now, tarry stools, black tarry stools is more common than vomiting blood with the duodenal ulcer. Complications of peptic ulcer disease include bleeding and actually having a hemorrhage or a GI bleed from that ulcer area. Those can be very serious, and patients can be very hypovolemic and in hypovolemic shock because of that hemorrhage and blood loss. Perforation of the ulcer, that is definitely a life-threatening emergency. We have several perforations every semester, it seems like, on second floor that we're taking care of surgically of a perforated ulcer. So it's a sudden event. They usually have severe pain. They might be vomiting. They typically can collapse because they have cardiovascular collapse because of the blood loss, hypotension, tachycardia. Again, they may have that rigid board-like abdomen, so we need to be watching for that. They would need to go to surgery right away. Pyloric obstruction, this is again where the pyloric sphincter is at the end of the stomach, the gastric outlet moving into that first part of the duodenum. So you might also see it worded gastric outlet obstruction or pyloric obstruction. And either way, that can cause nausea, vomiting. They might need a balloon dilation via endoscopy to be able to open that up better. And then finally, they can have what's called an intractable ulcer. Intractable ulcer means that there is failure to heal of that ulcer. So 12 to 16 weeks of treatment and it's still not healing. So sometimes if patients can't heal that ulcer, they might have to do a partial gastrectomy if it's a stomach ulcer to take out that area, or they might even do a partial bowel obstruction and take out part of that duodenum area. So that is a possibility. Management of peptic ulcer disease, as far as non-surgical management, certainly rest and stress reduction. We know that physical and psychological modifications can decrease the amount of acid being released. Certainly stopping smoking, because smoking does increase hydrochloric acid and other acids to be released. Diet, again, avoid foods that are troublesome for you. And again, alcohol, caffeine, milk, those are all things that we know can increase the acidity, and we can take control of that. Pharmacological therapy, so relieving symptoms with medications. We'll be talking about the antacids. If they have H. pylori, if they have a duodenal ulcer and H. pylori was the cause, they can be on antibiotics to treat the H. pylori. Surgically, they can do procedures, and I'll show you that here in a second, a vagotomy or Bill Roth 1, Bill Roth 2, which will remove the section of the troubled area, and then they will reconnect that back up. So we will be doing more with the medications in class as well. I'm not going to read the slides to you. You can see what's on there. I don't have a lot of extra things to add than what's already here, but just know that you do need to, of course, know examples of the types of medications, know how that particular type of medication is working as far as its action, and then hopefully with our different class activities too, we'll try to differentiate some of the specific nursing interventions for each category. So the anticholinergics will decrease hydrochloric acid by blocking the release of acetylcholine, and acetylcholine normally stimulates HCl, so that's how we're blocking and reducing the HCl acid. I think the biggest thing here is just to refresh on those anticholinergic side effects, and we did talk about them quite a bit in the mental health area with our antipsychotics and antidepressants. Both of those categories can result in anticholinergic side effects. So it's a good time here, even though we're not talking about that, just to remember a lot of the anticholinergic side effects that are important is just the dry mouth and decreased oral secretions, constipation, urine retention, may produce tachycardia, hypotension, so changing position slowly, etc. So the H2 inhibitors, you'll see a lot of these prescribed. They block the histamine release, which decreases the volume of acidic secretions. They all end in the D-I-N-E, so famotidine, cimetidine, ranitidine. So hopefully you've seen these medications and remember them as H2 blockers and reduction of acid. The proton pump inhibitors are probably the most readily prescribed. These all end in zol, so omeprazole, pantoprazole, so your Prilosec, your Protonix, your Prevacid. So again, a very, very commonly, probably your most commonly prescribed medication that you'll see for GERD and hernias and ulcers. We have dissolvable, we have liquid. I mean, there's different versions of how these oral meds can be given. We can give pantoprazole IV, the Protonix IV, so that's helpful as well. Again, this is a category that you'll see often and want to know. The coating agents, again, we've been talking mostly about meds that will reduce the acid, but we also, if you can think back to the picture of those big hollowed out areas, we need a medication that's going to provide the protective coat over that ulcer, over that big crater. And so your sulcrafate or your carafate is going to be the medication that you're mostly going to see prescribed for that. And the big thing with this is it does have to be given, before the meal. So it's supposed to be 1 hour before the meal. I mean, we need to get that area coated before they're going to actually eat, because of course when you eat there's more acid produced in order to break down the food that you're eating. So this would be very time dependent medication. So you should be able to verbalize and be able to differentiate between duodenal and gastric. We talked about gastric, the pain being a half hour to an hour after meals versus duodenal being a longer, 1.5 to 3 hours after meals. We talked about the gastric being just a normal or even a hyposecretion of acid, whereas duodenal ulcers definitely are a hypersecretion of acid. With that then, duodenal ulcers will have pain on an empty stomach and will have relief with food because of the hyper acidity that food neutralizes the acid, and gastric food doesn't make a difference because there's not hyperacidity, and in fact with gastric ulcers many times food can make it worse. And then one of the other big differences we talked about was that vomiting of blood or hematemesis is going to be more common with gastric ulcer, and blood in the stool or that black tarry stool is going to be more common for the duodenal type. The answer here is 4, and I would encourage you when we say, a mucosal barrier agent, what drug is that? Sucralfate or carafate would be that medication, so making sure that you're always able to recognize the generic name while you're learning these meds would be very important. The answer here is 4. This is showing the vagotomy. While it's not common, it's basically severing the vagal nerve and reducing that stimulation of the vagal nervous system, and that's how it's treating the reflux or the chronic acid production. This is showing you Billroth 1 or Billroth 2, so a gastroduodenoscopy or a gastrojejunostomy. Basically, it's just showing you where they're doing partial gastric resection, and then they're reconnecting either at the duodenum in Billroth 1 or they're reconnecting at the jejunum for Billroth 2. So again, this will be the same treatment for cancer or peptic ulcer disease if they have an intractable ulcer, and or if somebody had cancer, they might have to remove a portion of that stomach and then reconnect it with the intestine. And in this picture, this patient here had a total gastrectomy, and you can see that they have reconnected the distal portion of the esophagus with the jejunum. So if somebody had cancer severe enough where they had to take out the whole stomach because it needed to all come out to have clear margins, this is what their new anatomy would look like. So with gastric cancer, some of the main causes or some things that put a person at higher risk would be more smoked or pickled foods, less fruits and vegetables, gastric ulcers, again, a small percentage of a correlation there, chronic H. pylori infections or chronic gastritis. Again, sometimes it can be just more of a genetic predisposition for this type of cancer as well. 2 times more common in Native American, Hispanic, and African American than a Caucasian person. And usually age 40 to 70 is more of the age group that you'll see gastric cancers. Again, minimal symptoms early, which makes it tough because a lot of times they have more of a poor prognosis depending on if they have metastasis at time of diagnosis, but definitely symptoms of a progressive disease, nausea, vomiting, anorexia, weight loss, dyspepsia, abdominal pain. But you can see how a lot of these signs and symptoms have been the same for all this GI stuff that we've talked about so far. So a person's not just running to the doctor thinking they have gastric cancer when they're having these symptoms, but when they have them more days than not, lots of days in a row, months in a row, we can't ignore them. We really should get them checked out. And so not wait for a significant weight loss, not wait to have blood in the stool or vomiting blood, but to really listen to your body and get this evaluated sooner. So nursing care for the patient with gastric cancer, a lot of education, reducing anxiety, explaining what's going on, keeping everybody informed. There's a lot of fear of the unknown as far as prognosis. Nutrition is going to be very, very important. Smaller meals a day, no fluids with meals. We want to prevent the dumping syndrome, and we'll be talking more specifically about that. Antiemetics might be prescribed before meals, even if they're not having nausea, vomiting, just to help promote peristalsis, but also to just reduce their chance of becoming sick, because when they get sick and you've had surgery in that area, it makes it very painful to vomit. So we want to kind of help be proactive with that. They may need supplementations, might need total parenteral nutrition. They obviously will be on an acridino and a daily weight. Again, relieving pain, that would be the same as any type of a surgery, having them splint with deep breathing and coughing. I mean, they've had a major abdominal surgery, so all applies to what we know for patients with abdominal surgery: early ambulation, TED Talks, leg exercises, pain management. So I'm just trying to emphasize the things that are different. Specifically, nutrition is a huge deal, and they're going to lose some weight, so we want to try to keep them from being protein malnourished. And then again, all of the psychosocial support and extra time to answer their questions involving the family. They're going to have to make some decisions. Are they going to go home and have some TPN for a while? Are they going to have a feeding tube for enteral feeding? What sorts of things are they going to want to do, or how aggressive are they going to want to treat the cancer? So this just felt like a good time just to insert a little bit about PPN and TPN again. And then I like this picture because it shows you the parenteral nutrition, the partial parenteral nutrition, and the total parenteral nutrition, which is intravenously. And then it shows you, if they have a gastric tube, a jejunostomy tube, a G tube or a J tube are going to be the most common. We rarely feed through an NG tube anymore, but if they need something permanently placed, that would be a possibility. So again, I really want you just to review your responsibilities with parenteral nutrition and enteral nutrition. We covered that in skills lab in 3rd semester. Watching for their labs, evaluating their prealbumin and their albumin, and making sure that we understand if we are doing total parenteral nutrition, we have to have a central line in place with a chest x-ray verifying that before we start that up. So very, very common for patients with major GI surgery, especially an actual gastric resection, to have TPN for a bit. So just a nice picture of the bags. Of course, just the clear yellow, brighter yellow. There's no lipids added to that. But if you see a big TPN bag that is more milky white, that means that they have added the lipids. And then you see the best practice standard of care is really to do the separate TPN and the lipids separate. So you're going to be more likely to see just a small little bottle of lipids that we hang over 12 hours. And then of course the regular TPN bag, the brighter yellow, continues to run continuously and gets changed every 24 hours. So indications for gastric surgery are listed here. If we have any perforation of a GI organ, active hemorrhaging of an ulcer, gastric cancers, can have it for weight loss surgery. We just had a patient that had major trauma that had a perforated bowel because of a car accident. So again, there's lots of different reasons to need gastric surgery, but if they do, it's going to be the same sorts of procedures. Partial gastrectomy, Billroth 1 and 2, and total gastrectomy being the most commonly performed depending on what is actually needed. And so one last time, here is the gastrectomy, a total gastrectomy. You can see where they've removed the whole stomach and they have reconnected the lower end of the esophagus with the jejunum. So the site of anastomosis is at the jejunum, and that is going to put a patient at higher risk for dumping syndrome, and we're going to talk about that because normally we go through the stomach, and then the stomach has that pyloric sphincter, the gastric outlet, that can help control the rate at which things are going into the intestine. And here it's just coming right from the esophagus right into the jejunum. So dumping syndrome is a serious concern after this sort of a surgery, and we'll talk about how we can try to slow the emptying there. And here again is the picture of the Billroth 1 and 2. So again, if they just have a portion of the stomach that is injured or perforated, or the ulcer or bleed or trauma, then obviously they're not going to take the whole stomach out unless they absolutely have to. So then we can just reconnect up, take out that portion of the stomach and then still reconnect it up more of a normal anatomy where we're going to have less risk of dumping syndrome. There's still risk of dumping syndrome, especially if that pyloric sphincter has been involved and we no longer have that. Nursing care postoperatively then for these GI surgeries, hemorrhage, again, it's going to mostly be internal bleeding, also monitoring what's coming out in the Jackson-Pratt drain if they have it, certainly checking abdominal dressings. If they have an NG tube, what does that consistently look like and what is that amount? Dumping syndrome, I'm going to be talking about that separately here in a second, but that is where we have rapid dumping of food into the jejunum, and that can be produce very uncomfortable signs and symptoms, so we'll talk about how to prevent that. Pulmonary complications, like anything, oxygenation, lung sounds, coughing and deep breathing, early ambulation, splinting the incision, and if they are hesitating with that and not having good lung perfusion or lung expansion, then we need to get them up and going better. So even though it hurts, there's tummy, we need to help them to make that progress. Steatorrhea, unabsorbed fat in the stool. This can result as we have rapid gastric emptying without adequate mixing of the pancreatic and biliary secretions, and so it's possible to have more of that unabsorbed fat in the stool. Vitamin B12 deficiency, we talked about early on as a function of the stomach, that B12 is absorbed once we have released this intrinsic factor in the stomach, which makes the B12 absorption possible. So if you have a total gastrectomy and take the whole stomach out, then you're for sure going to need B12. If you do a partial gastrectomy. It will just kind of depend on that patient, but you definitely have lost, you have a less amount of intrinsic factor, so you still may need B12 for life. Nutrition, again, we just talked about nutrition. I don't know that I need to talk about that again. Mainly TPN would be appropriate for a lot of patients, and they'll have a central line. And then again, just all of the client education related to things that we've been talking about. Dumping syndrome is a common complication when the pylorus is bypassed. The pyloric sphincter, as you remember, is at the distal part of the stomach, and that sphincter allows the emptying into the first part of the small intestine, the duodenum, and it does so, it regulates it. So if we are having that area bypassed, it's more likely to have what we call rapid dumping of food into the intestine. So postprandial or post-mealtime problem, again, after a person eats, that you would have a rapid dumping of food into the jejunum without proper mixing of digestive enzymes. So when we looked at some of those bypasses, if we had taken the stomach out or a portion of the stomach out, they could hook the patient back up either at the duodenum or the jejunum. And many times the Billroth 2, where they hook up at the jejunum, is more commonly used, and so that's where they're talking about the food dumping right from either the esophagus or a smaller portion of the stomach into the jejunum where you don't have the pyloric sphincter involved anymore. Early signs and symptoms, again, they can be very, very uncomfortable for patients. Just a real severe epigastric fullness, distension, so they get really sharp pains in their stomach and cramping, and just feel like the worst case of bloated or distension that you'd ever feel. And again, this is what patients normally report. They have a pretty significant nausea. They usually get real cool and clammy and pale, may or may not have palpitations. Again, they're feeling really sick from that rapid increase in blood sugar. That's what those early manifestations are from. So that rapid dumping, feeling full, rapid increase in the blood sugar. Again, the hypertonic intestinal contents draw all of that extracellular fluid with it into the jejunum. And so it's just a high concentration of both electrolytes and sugars that result. Late manifestations, usually 10 to 90 minutes after, they still may have some symptoms, but again, that initial symptom, usually they're feeling quite sick initially, and sometimes everybody's different, but it may take anywhere from an hour to 2 hours to really get through it. Sometimes people might have a rapid dumping syndrome that just comes quickly and passes quickly, but it can persist. The main management for dumping syndrome is to try our best to delay that gastric emptying time. So whereas with GERD, we want them to stay sitting upright so that they don't have that gravity reflexive acid backup. With dumping syndrome, we actually would like them to assume more of a low Fowler's position during mealtime and possibly even lie down afterwards. Again, if we think of gravity, that would help keep the foods not dumping in as quickly. So 20 to 30 minutes after low Fowler's or lying down, again, try to let gravity help with that. Also, not having fluids, typically no fluids with meals, and even, if we can avoid fluids 1 hour before and after meals, that would be ideal. That we don't want to get all full with fluid instead of just having the carbohydrates or the solid stuff, but then also the fluids just helps it dump quicker, if that makes sense. So ingestion of fluid causes the stomach, those stomach contents to enter into the jejunum too rapidly. So small frequent meals, less fluids, less real sugary or the short or the simple carbohydrates such as sugars are usually not as good as well. Again, meals to contain more dry items, so not a lot of liquid items, especially with the meal, and then no extra liquid with the meal as far as water, juice, etc. The other thing is we'll talk about dietary supplementations. In particular, the patient may need extra vitamin B12 supplementation As we talked about, if they were removing their stomach or removing a portion of the stomach, they may not be absorbing enough dietary B12. Anticholinergic medications such as atropine could be helpful to kind of suppress some of the action of the symptoms here and suppress some of that dumping as well. This is a really nice creative memory slide which talks about 15 to 30 minutes after eating when the patient's going to get these symptoms. It shows the dump truck where you have high carbs, high fluids, high sugar content where they'll dump the stomach contents into the duodenum without adequate mixing or directly into the jejunum. That part depends on the anatomy of the patient, what types of surgery they've had, which puts them at higher risk for the dumping syndrome in the first place. So usually a total or a partial gastrectomy would be your high-risk patients and your weight loss surgeries where in fact they have basically bypassed a big part of the stomach and hooked up at the jejunum. So you'll see the symptoms, tachycardia, palpitations, and then you see no fluids with meals, no high carbs. The high carbs, both simple and complex, can be very problematic. The correct answer here is 4. This is where, again, if the stomach is removed, a gastrectomy, the stomach is removed for gastric cancer, there is no intrinsic factor that is then, because that's normally released in the stomach, that is necessary for the absorption of vitamin B12. So they will need a replacement of vitamin B12 that comes in multiple routes. It comes in sublingual, sub-Q, IM, nasal, and also also foods that are high in vitamin B12, meats, seafood, egg yolks, fermented cheeses, those are also things that we can talk to our patients about. But even if they increase foods high in vitamin B12, if they have removed their stomach, they will be getting synthetic replacement via some other route. Morbid obesity. Patients with morbid obesity have 2 times greater risk of dying early. There are different, qualifications and kind of equations to kind of determine if they have morbid obesity, but more than 2 times ideal body weight if they have a body mass index greater than 30. Again, body weight greater than 100 pounds of their ideal body weight. There's different ways that we can quantify that. Just know that, even if a BMI of 25 to 29 is overweight, so certainly once we get to 30 or greater, they would qualify that as morbid obesity. There are lots of different causes for obesity. I think the biggest thing is to understand that this isn't necessarily everybody's choice and their own lifestyle and eating and not exercising. While dietary and sedentary lifestyles certainly can impact, there are endocrine disorders, such as hypothyroidism that can contribute. Maybe they have endocrine or other immune disorders where they need to be on prednisone or steroids, which consists of a lot of weight gain. And again, genetic factors. We know that genetics play a big part in our body style and our shape and what we're going to have for metabolism and things like that. So I think it's very important not to be judgmental, obviously, of people that may or may not be overweight and or morbidly obese. As far as health-related complications, I always want to be thinking about what we call comorbidities. These are diseases that also can cause complications and can result in long-term disability. So cardiovascular disease, hypertension, atherosclerosis. We know that obesity doubles the risk of hypertension and increases, puts people a 70% chance of having other incidents, cardiovascular disease related to obesity, so maybe strokes, heart attacks, etc. Arthritis, we know arthritis, osteoarthritis, degenerative joint disease. This is a big problem when people are overweight. It can affect the breathing, so more risk of asthma, chronic bronchitis. Certainly we know that morbid obesity impacts a person developing diabetes because that's a big part of the insulin resistance with type 2 diabetes. And then we see a lot of people with morbid obesity that also have concurrent sleep apnea. So there's lots of different things that we're going to look at with morbid obesity as far as physical comorbidities. We also want to think about the emotional comorbidities such as anxiety, depression, low self-esteem, etc. So for bariatric surgeries, there's lots of different types of bariatric surgery. We're not going to necessarily be experts in all of that after we are done here, but I do want you to understand that there are several different things that have to be done pre-surgically. Patients have to show an X amount of weight loss, start good healthy eating and exercise programs. They have to have a full psychological evaluation. Most insurance will require at least a minimum of 2 comorbidities for them to pay for that surgery. This doesn't take much because, hypertension, diabetes, osteoarthritis, anything like that would be a comorbidity. And then they do meet with a dietitian, usually about 6 months prior to surgery, and really get started on what this is all going to mean to them, to their lifestyle. Is their family supportive? Are they going to be, able to do this? Bariatric surgery has been going on since the 1950s, but we have a lot more options and a lot better minimally invasive bariatric surgeries as well. As far as the Roux-en-Y and the sleeve, those are the two that I'm just going to talk about. The Roux-en-Y, patients are losing weight by restriction and malabsorption. So restriction meaning that about 90% of the stomach is removed. They basically create a 30 ml pouch. So they cannot eat large volumes of food, and so that's part of how they are losing weight via the Roux-en-Y. Malabsorption is also part of the weight loss because we are bypassing a big part of the small intestine. Remember, small intestine is responsible for our absorption of nutrients. Because we're bypassing a lot of that, there is malabsorption, and when we're not absorbing, we are going to have weight loss. So again, the Roux-en-Y really is good for long-term weight loss because it really doesn't happen quickly. It happens over time, and so there's usually better results of not gaining it back. The sleeve gastrectomy is another really great choice, and this uses restriction. About 80% of the stomach is removed. The benefits of a sleeve gastrectomy is there's typically full recovery in 4 to 6 weeks, although with a laparoscopic Roux-en-Y there can be recovery at about that time period as well. But the benefits typically don't need protein shakes and vitamins for life. They can just basically do their regular dietary restrictions and eat healthy. Whereas with the Roux-en-Y, because there is more weight loss from the malabsorption, there's more need for replacement of vitamins and nutrients that they're not absorbing. So that's kind of one of the main differences with the two types of procedures. So the picture on the left is showing you the gastric bypass via the Roux-en-Y. Again, can be recommended for long term. You can see where they have like a 50 milliliter or less stomach kind of right at the top, and then the rest, then they hook up the jejunum to that stomach. So now we go from the esophagus into that small little stomach and then directly into the jejunum. So we're bypassing that whole segment of the duodenum, bypassing a big portion where we're going to have more malabsorption, and then obviously can't eat as much because of that small pouch. As far as the one on the right, this is a picture of Marlick's band, vertical banded gastroplasty. I don't know if we see a lot of bands anymore, but you can see where there's a band that they place where they create like a 15 milliliter pouch. The advantage is that this is more reversible. I mean, when we do a Roux-en-Y, it's not going to be reversed. There is slower weight loss over time, so that is a good thing as well. And then also, though, the disadvantage is that this can stretch. So obviously, if we're overeating, that pouch area is going to stretch. So it can get where we have the same, a larger area, a size of a stomach than we want as far as compliance with diet. This is a picture of the vertical sleeve gastrectomy. So you see the gastric sleeve is the new stomach. The beauty of this is it most closely looks like the regular anatomy. So we're just making the stomach smaller, but we still have the pylorus and into the duodenum. So it's basically weight loss by restriction only. We're not gaining weight loss from the malabsorption like you saw with the Roux-en-Y. If they're doing laparoscopic weight loss surgery, this is the red dots are where you would expect to see several laparoscopic sites, scope sites. And the biggest thing also with obesity is just thinking about the increased complications post-operatively. So laparoscopically is more ideal because if they had a bigger incision, there would be more chance of dehiscence and evisceration. more increased risk of infection, etc. So laparoscopic will lower that risk of the wound dehiscing, lower the risk of infection, quicker healing time, can get back to work sooner. So many advantages of laparoscopic, but they certainly do not go without complications. Laparoscopically, there's not direct visualization, so there is the chance of leaks at the site of anastomosis. So the site of anastomosis is where they reconnect. So for a Roux-en-Y, that would be the new little pouch, stomach pouch to the jejunum would be the site of anastomosis. And so if for some reason there was a small little area that the suture popped out and there could be a small leak at that area, then obviously they could slowly be leaking bacteria into the peritoneum and end up with a peritonitis. Some of the complications of gastric bypass surgery are listed here. I just got done talking about leaks at the site of anastomosis resulting in peritonitis. So we do need to be aware, as we are with all patients, to be looking for elevated temperature, but also elevated heart rate, elevated respiratory rate. If they have more of a left shoulder strap type pain, that might be from the laparoscope where they have the carbon dioxide used for the laparoscopic procedure will rise, and so that's where the left shoulder pain, some of the shoulder strap pain can come from, normally from a laparoscopic procedure. But if they're having more than just a little bit of that shoulder pain and then also the heart rate and respiratory rate and temper up, we need to be thinking of a serious complication like peritonitis. The other thing is they typically will have a Jackson-Pratt drain, so if you're starting to see large amounts of fluid coming out of that, they could also indicate a leak. So we got to be on our toes. We got to be watching for some of these nonspecific signs of complications. Infections, again, low infection rates, but again, 7 to 21 days typically for an actual wound infection to be happening. So we'll be typically not seeing them in the hospital. They will be at home and needing to be able to report signs of infection. Dehydration by far is the biggest complication following gastric bypass surgery. So they will be on IV fluids in the hospital. We will be doing small amounts of fluids. We have a whole regimen where they will, start on clears and waters and be basically taking 15 to 30 milliliter increments of water at a time. We'll be checking acrid INO. They will have be on acrid INO, whether or not they have a Foley or not. That might depend on the site that you're working, but either way they will definitely be on strict INO for intake and urine output. So dehydration and other metabolic imbalances such as low potassium, low magnesium, some of those things, again, as we think of the malnutrition and the malabsorption, we got to be watching for those both early but then also late. But dehydration definitely is the reason for post-bypass patients to have to come back to the hospital after this type of surgery. Deep vein thrombosis, we know that more obese patients, the more weight you have, the more chance of developing this complication. So we'll have a very strict regimen with early ambulation and activity. They'll be walking every hour. They'll be have their antithrombic boots on and all of those things to try to prevent, as well as prophylaxis, enoxaparin or heparin. Pneumonia and atelectasis, of course, with more weight, there is more chance of less lung expansion. So we'll definitely want to keep their head of the bed a little bit more elevated, use oxygen initially, encourage that incentive spirometer, coughing and deep breathing. Most gastric bypass surgery protocols will have them staying on a continuous pulse oximetry also for that first 24 to 48 hours. Vitamin and mineral deficiencies, we talked about that really are going to need a lot of high protein and just really good healthy foods. They also may need other replacements such as vitamin B12 or folic acid are some of the common ones, and they'll kind of just have to wait and see how they are handling and how much they are reabsorbing on their own versus what they might need for synthetic replacement. And then risk for impaired skin integrity, again, is always a problem, always a big concern for anybody that is overweight. We do have special bariatric pressure reduction beds. We also, like I said, hopefully can do it laparoscopically. If we have to have a midline incision where they had to do an open surgery, a lot of the times with people that are heavier, they will have them use the abdominal binder, so they'll have that big corset that will help kind of keep things tight so that when they're moving and repositioning, something doesn't pop open. So again, watching for wound dehiscence, knowing that they will have a delayed wound healing also. They have less blood supply to fatty tissue, so they're going to have less blood supply for healing as well. Nursing management and teaching. There's a lot of education that goes into any teaching for somebody after surgery, but in particular all the details and different things that for weight loss surgery patients. So I know if you're working at a facility where they do bariatric surgery, they typically do some pretty intensive training for the staff, for the RNs, about the procedure itself, about the diet, exercise programming, what all has gone into what the patient has done before they get to you. I think it's very important for us to understand the whole entire process, not just the surgery itself and the post-op plan. So they will typically be on a clear liquid diet for 7 days. Then, and again, this is approximate, depends on what type of procedure they've had and where they had their surgery. They all kind of have a little variation in routine, but then usually for 7 days to about that first month, 28 days, they'll slowly advance to full liquid. Then they'll typically be on more of a pure read for 4 to 6 weeks where everything is blended. And then after that, like 6 to 8 weeks more of mechanical soft. So again, you can see this is a very long progression or very long period of time where we're actually getting adjusted back to what might be more of a normal diet. But even then, the diet is a new normal. They still have to look at protein and fiber and just adding all good healthy things. Not that they can't ever have other treats and sweets and things, but they do need to really get kind of on a good routine and get their body adjusted. One other thing that we talk to them about is just chewing very well. So they typically like them to chew at least 20 times or get it to basically whatever food we have in our mouth, to more of an applesauce consistency before we would swallow, and just to eat slowly and chew thoroughly and avoid liquids during the meals initially, and avoid liquid calories like alcohol, fruit juices, and colas. That's kind of some just big general ideas behind nutrition for weight loss surgery. Obviously, an exercise program is very important. All of the psychosocial management that goes into it, just the new body image, how everybody else is reacting, how you're handling it, etc. Prevention of complications. We talked about most of the common complications on the last slide. So what we're going to do is just do all of that very detailed assessment and monitoring for early signs of complication. That's our biggest job. So yes, they're going to be on IV fluids. We're going to be doing at least every 2-hour urine outputs. We want to be monitoring their labs for dehydration. We want to be checking that again for a low urine output and a high heart rate. You know, those are some of the earliest signs of third spacing and dehydration. So we want to be able to be watching for that. Continuous pulse ox, like I mentioned, making sure that they're staying above 90%, early ambulation, antithrombic boots, pressure reduction beds, all of those things are going to help prevent the complications that we talked about on the last slide. And then checking for signs of leak leak at the site of anastomosis. You know, they will typically do x-ray the morning after a laparoscopic procedure to make sure that everything is connected properly and there's no leaks at the site of anastomosis. And if they are doing that, most physicians will have their patients stay NPO until they for sure know that there's no leaks at the site of anastomosis. So if they are NPO for that first 12 to 24 hours, that's why. And then they'll start on that clear liquid and, as I said, gradually be advancing. The liquids also should be at room temperature. We don't want anything too hot or too cold. We also don't want to use any straws, and it makes sense if we're drinking through a straw. We also could be consuming air, and we don't want to put air into the little stomach. We want room for our food and fluids, so we don't want it to be filled with air. There are also really good protein shakes. Obviously, you're familiar with Ensure, but there's also more of a fruit-flavored protein replacement, so lots of different options for them. The other thing is just the equipment, making sure you have large enough blood pressure cuff, making sure you have large enough wheelchairs. So again, if you are working in a program for bariatric surgery, you'll typically have all of that sort of equipment and the bigger beds, the bigger wheelchairs, and everything that would accommodate your patient population. I like this picture just because it shows you a couple of the drains. B is where it shows the Jackson Pratt, and so again, depending on the type of bariatric surgery, they might have a Jackson Pratt drain. We typically see Jackson Pratt drains with if anybody has an abscess or abdominal type infection. You'll see Jackson Pratt drains most of the time with our prostatectomies. So again, you'll see them for a few different surgeries. So if those of you who haven't seen a JP drain, it's that bulb syringe, and the biggest thing is it has to be compressed in order for the suction to work. So we want to make sure we're emptying it, when it's, not quite a half full, because as it fills, the bulb expands, and we want that bulb to be compressed for the best suction. In A is a Penrose drain. You don't see Penrose drains very often, but if you do hear that your patient has a Penrose, they have a drain that looks just like that, where there's no collection device on the end of it. So the Penrose drain just drains right into a sponge. So we'll have the gauze sponges that it's draining, and there'll be more frequent dressing changes. C was kind of an old version Hemovac for hips and knees, but you don't really see those anymore. You will certainly take care of patients with bowel obstructions over the course of your career, and there are a few different types. There's the mechanical cause, I should say, and then there's the functional cause. So the physiology is pretty straightforward. There's a failure of the bowel contents to be moving forward. So there is buildup of intestinal contents, fluid, gas, and all of that accumulates above wherever the obstruction is, and then of course they get distended and get nauseated, can vomit, etc. So the most common area for the obstruction is the ileum. That's the smallest diameter of the intestine, but it isn't just necessarily the size. It might be some other forces that are causing it to be narrowed or smaller. So the mechanical type causes are forces outside the intestine that are actually pushing on it. So this is a really common cause of bowel obstructions, where people have tumors or herniations or something like that that's causing the area of obstruction. Or another common is the adhesions. Adhesions is scar tissue. So if patients have had other abdominal surgeries, they might have a lot of scar tissue, which is causing that force on the intestine that's causing that narrowing and obstruction. Functional impairments for obstruction are not as common, but this would be more an impairment of the muscle tone, the peristalsis. So this can happen after anesthesia and major abdominal surgeries. We call this, when they have this sort of a problem, they may have developed what's called a paralytic ileus. And I say paralytic, paralyzed ileus. Ileum is the bowel, so a paralyzed bowel. This is where peristalsis isn't happening, so everything, we don't really have a mechanical external thing, something obstructing. We just have the bowel that's not having peristalsis, and so obviously everything's sitting there and then not moving through. And that's where they're getting their symptoms. With intestinal obstruction, the symptoms are pretty much the same. I mean, they can vary as far as severity of symptoms, but most patients have very similar complaints. They have crampy pain, they have colicky pain, they're not passing gas, they're not passing stool. They might, if they are, they're only passing a little bit of mucus, but no real fecal matter. Again, biggest thing is nausea, vomiting, and again, pain and distension. Their abdomen will be distended and more firm. So all of those things indicate that there has been intestinal and gastric contents that are building up above the obstruction, right? And so that's causing all of those things to happen. They may have high-pitched bowel sounds proximal to the obstruction, and then absent bowel sounds distal to the obstruction, so that tells us that things aren't moving through. So again, we would expect to hear probably hypoactive or absent bowel sounds for sure, distal to the obstruction, and we may or may not hear kind of more of a high-pitched proximal to the obstruction. So we'll definitely keep them, they'll go on NPO status for bowel rest, so we'll do mouth cares, etc. with that. They'll most of the time need a nasogastric tube placed for decompression of the bowel and to remove all of those contents that are sitting in there, and that in itself will decompress the bowel and relieve a lot of their initial symptoms. They may or may not need surgery, and again, this depends on the cause of their obstruction. So if there is a herniation, scar tissue, and more of those mechanical causes, for the mechanical type obstruction, they're going to need surgery to fix that. Bowel rest and NG decompression isn't really going to fix a mechanical problem, a piece of scar tissue that's blocking things, right? That makes sense, hopefully. They'll be on acrid I&O. Of course, we'll be keeping track of the NG output. Make sure that if the doctor does have them, that they can have ice chips. They mean sparingly, so first of all, we need to manage that. One of our surgeons allows them to have one popsicle a shift, just more for psychosocial and comfort and to wet their whistle. We just have to make sure if anything's going in that has been okayed by the physician, that we need to subtract that from their nasogastric output so that we are recording an accurate amount of what's actually coming out of the nasogastric tube and not that we put in. Again, we can't be putting anything. They can't have anything. If they have NPO, it means NPO. But some may write NPO with ice chips or something like that. So just make sure that you have an actual order if you are giving them anything. IV fluids, and typically they'll have IV fluids with potassium replacement, right? Because hypokalemia is very, very common with NG suction or GI losses. So again, added potassium would be expected. We'll be really watching that potassium level, but we'll typically add potassium to the fluid, hopefully before the potassium ever gets low in the first place. Pain management is going to be important. IV Dilaudid, IV morphine, something to help them keep them comfortable. Also, it's going to be important for them to be walking and moving, so we want them comfortable enough to do that. If they are going to have an acid-base imbalance, they would most likely have metabolic alkalosis because they have more of a chance of having hypokalemia. That pH will be high. This slide shows some of the mechanical causes for intestinal obstruction. So A is called intrasusception, and this is where you have like the telescoping of the bowel, so movement of one segment of the bowel into another. B is volvulus of the sigmoid colon. This is where it twists, and in most cases twists and turns in itself and can cause problems. C is a hernia, inguinal hernia. So again, you can see how that's twisted and can definitely will cause an obstructed area. And then we don't have a D listed on here, but I do want to again reinforce adhesions is a very common cause, mechanical cause of intestinal obstruction, where they have adhesions or scar tissue after an abdominal surgery. And so those adhesions produce a kinking of that intestinal area and need to be removed in order to fix that obstructed area. Just a quick review on nasogastric tube. Of course, the nasogastric tube will be what's placed into the stomach, and then it'll be on low intermittent suction. Again, remember with the nasogastric tube, that will help to decompress the bowel. It's successful in many, many cases. Watching for low potassium, doing an acrid I&O, making sure that we're turning off the suction prior to listening to bowel sounds. Those are just a few things that we want to make sure that we are watching for. Obviously, we're doing a focused assessment of the abdomen. We're hoping that their abdomen will be less distended. We're hoping that their firm abdomen will become soft, that their nausea and vomiting will reduce or cease altogether, stop. So all of those things are important. This slide also shows the other types of enteric feeding tubes, so gastrostomy and jejunostomy. So just a nice review on that. We will next move into talking about the inflammatory bowel diseases. So Crohn's disease and ulcerative colitis are the two inflammatory bowel diseases that we will be discussing. In this picture initially, you can see I really like how it shows the locations of where we are most likely going to see the disease to happen. You can see that the Crohn's disease is more scattered and spotty, and the ulcerative colitis is typically more on the distal end of the large colon, so the descending, sigmoid, and rectal area of the colon. And that will be helpful as we start talking more about the physiology. We will much more likely see rectal bleeding with ulcerative colitis, and hopefully that location of where we're looking at the disease helps with, for example, understanding where that bleeding would be more probable of that area versus the Crohn's disease. So Crohn's disease, also known as regional enteritis, usually is diagnosed early on in life, so you can see peak onset between 10 to 30 years. It is equal by gender. There does seem to be a genetic predisposition by the mother, also greater in smokers. Otherwise, it is can occur anywhere along the GI tract, but the most common is the distal ileum and the colon, especially the ascending colon. So it is a disease that affects all layers of the bowel wall, so we'll talk about some of the differences, and Crohn's disease does extend through all layers of the bowel. It is more patchy. If they look via endoscopy, or colonoscopy rather, they will see the cobblestone appearance, and it's very deep and penetrating because it's going through all the layers, but it looks kind of cobblestone and very patchy lesions. So they'll have different areas of the patchy cobblestone if they were looking via scope. Characteristics, it definitely can have more exacerbations and remissions. So sometimes if patients can get on that right immunotherapy, they can have good results, but then they might have some flare-ups, and again, some people do have more difficulty getting their disease under control. So when you're studying, it will be important to differentiate between Crohn's disease and ulcerative colitis. One thing that you will note, both of them have more frequent stools, so Crohn's disease, diarrhea, loose stools 5 to 6 times a day, whereas ulcerative colitis can even have more than that. One area also is that the pain area will be different. So with Crohn's disease, it's right lower quadrant abdominal pain typically. And if you think of it's most common in the ileum, that's the primary location, that ileum will be located in the right lower quadrant. So we can understand the location if we know where the most common or first area of the Crohn's disease will occur. The other thing where I just kind of easy to remember is the R in Crohn's disease for right lower quadrant, and ulcerative colitis we'll talk about left lower quadrant, and with ulcerative, the L in ulcerative can remind you of left lower quadrant. So those are some other ways they may help you to initially remember that. But I'd love for you to think about the ileum being the common location and remember the right lower quadrant that way. They may have some non-specific signs and symptoms like fatigue, malaise, weight loss, malnutrition. Again, typically patients with Crohn's disease are very thin, may have protein malnutrition, may look, emaciated. Not everybody with Crohn's looks emaciated, but I'm just saying this might be a problem because they do definitely, everything's going through them very quickly, so they have some malabsorption with losing so much stool every day. They may have steatorrhea or more fat in the stool, again, if it's not being absorbed and it's moving through quickly the bowel and being excreted quickly, fat is more likely to be in that stool. Anemia, again, less time in the intestines to absorb the nutrients that are needed, so anemia certainly is a possible complication of Crohn's disease, as is other nutritional deficiencies. Now, complications, we always want to be thinking about the potential for abscess formation, which would look like sepsis or peritonitis, intestinal obstructions, small bowel obstructions can occur, and then really honing in on the malnutrition, anemia, and things that are resulting from their disease. So diagnoses of Crohn's disease, based on their symptoms, they can get a lot of good information, but ultimately to confirm diagnoses, they will most likely do an endoscopy and or a colonoscopy or both. Many people that are having extensive bowel problems will have both an endoscopy and a colonoscopy, because the endoscopy can go all the way down to the ileum, and then the colonoscopy can go the whole large bowel over to the cecal valve, which is basically right at the ileum there too. So they can basically see every inch of that patient's intestinal anatomy and intestinal tract. So either or and or both is pretty likely, especially they want to be very accurate. We want to confirm diagnoses accurately and just check out how much inflammation or changes are happening. A barium study or a string study, this is an x-ray of the terminal ileum, and they will see constriction of that segment. So there is some less invasive things, but ultimately, typically the GI specialist would recommend an endoscopy and or a colonoscopy or both. Definitely going to look at the complete blood count because we're expecting possibly some anemia, so we want to see where they're at with their hemoglobin, even their ferritin and folic acid and some of those things. White blood cell we would expect to be elevated, as would erythrocyte sedimentation rate. So the SED rate is that erythrocyte sedimentation rate, and we know that a normal inflammatory response, which is happening especially with the exacerbations of Crohn's disease, would show elevation in white count and an elevation in the SED rate. Doesn't mean that they have an infection just because their white blood cell is elevated. It would also depend on other factors and other signs and symptoms. Now, albumin or total protein, if they're having issues with malnutrition and absorption, we might expect their albumin or total protein to be down. There are some nice Creative Memories notebooks on Crohn's disease versus ulcerative colitis. So again, you can look at those and do some comparing and contrasting. So the first big difference with ulcerative colitis is that this is an inflammatory condition of just the mucosa and submucosa. So whereas Crohn's disease affected all layers of the bowel, the ulcerative colitis is just the mucosa and submucosa. The peak onset you'll see is a little bit later, not quite as early as we see with Crohn's disease. It's still, ulcerative colitis still can have exacerbations and remissions, still can have ulcerations developing throughout the colon, but most likely happening in the sigmoid colon and rectal area. So a little bit lower on that large bowel, that descending colon, sigmoid colon, and rectum is the most common location. So location is different. Only 2 layers are affected with ulcerative colitis. Those are the first couple differences physiologically. So with ulcerative colitis, they still do have diarrhea and frequent stools, but you'll see here they can have 10 to 20, where it was more like 5 to 6 for Crohn's disease. Obviously, this is very individualized. Both of them are going to have frequent stools and probably not ever have real solid or formed stools, but there is more of a possibility with more frequent with ulcerative colitis. The pain location, of course, you can see here is different again. Remember, left lower quadrant because it's more commonly located in the sigmoid colon, which would be where the left lower quadrant is. Remember, Crohn's disease was right lower quadrant because we were mostly looking at Crohn's being active in the ileum, which is the right lower quadrant. Again, you can also look at the L in the ulcerative colitis and think of left lower quadrant, and the R in Crohn's disease for right lower quadrant as another way to help you initially remember these things. Anorexia, weight loss, still can have the same stuff as far as weight loss, dehydration, malnutrition, abdominal cramping, diarrhea. All of those things are the same. The biggest thing is the pain location and also more frequency of stools. I want to add on the last slide that I forgot to mention too, the rectal bleeding. I said it earlier, but I just want to make sure I say it again here. With ulcerative colitis, they would be more likely to have more of rectal bleeding because of it being, its disease location being more commonly in the sigmoid and rectal area, rectum, that they might have more chance of bleeding. As far as priority nursing diagnosis, we want to look at pain. We certainly want to look at altered nutrition. Their nutritional status is a really big deal. Fluid volume deficit, any electrolyte imbalances that might be happening. There is an actual nursing diagnosis, diarrhea, so obviously that would be applicable. Again, just a lot of teaching, knowledge deficit, teaching. You know, they might have disturbed body image because they do tend to be more thin looking and sometimes can look malnourished. I mean, many times they don't, but also just think of the body image and the social things where you never know when you're going to have to get to a bathroom. So that must feel very scary, and just, you know, not knowing and always kind of having that fear. For management of inflammatory bowel disease, we're making a lot of headway. There's a lot of research being done in this area to help improve and find better treatments for patients with inflammatory bowel, because once they're diagnosed, they have it and they'll have it for life. So it's one of those diseases that we want to help to manage as best as we can for quality of life, for reducing inflammation, and just having them be able to, not have as much, malabsorption and things like that. So our primary goal goals, because it is an autoimmune inflammatory type disease, is we want to reduce inflammation and sort of suppress that overactive immune system and immune response. So you'll see them being on a lot of immune suppressant type medications that we sometimes see more for cancer treatments and rheumatic disease. So immunosuppressants, we'll talk about what some of those names are here in a minute. And we want to provide rest, especially if we are in an exacerbation where we have really acute inflammation and flare-up. Some patients might need to be hospitalized during that time, be on antibiotics just to prevent infection, maybe have bowel rest, NPO, may need an NG tube at that time, and certainly would need IV corticosteroids, solumedrol. Methylprednisone is the generic name for solumedrol, if they're having a real acute active inflammatory response. Otherwise, they'll manage their Crohn's disease at home and hopefully be able to not have a huge amount of those flare-ups. Improving quality of life and getting them with support groups and education, and talking with other people that are also experiencing some of the same things. Nutrition therapy, they'll typically want low residue. Again, we don't want to have a lot of residue and fiber in bulk because things are moving so quickly already and they're having diarrhea and loose stools. So we want to kind of be a little bit lower on that type of food items. Definitely we'll want more high protein and high calorie. Typically, cold foods can be more of a stimulant or an irritant for peristalsis, and smoking as well. So we want to avoid those things. Some patients will know just in themselves what foods that may exacerbate their symptoms. I know my uncle has had Crohn's disease his whole life, and he just knows, like, oh, I'd really like that, but nope, can't have raw vegetables, can't do much for fruits, can't have much for whole grains and breads and cereals. Again, seeds, nuts, popcorn, I mean, we know those for sure for diverticuli, but those also can be irritants for people with inflammatory bowel disease as well. I was also going to add that many people with ulcerative colitis or Crohn's disease or inflammatory bowel may have a concurrent lactose intolerance, so they sometimes have to be a little more careful with their lactose intake or amount of lactose intake. So moving into the pharmacological management and surgical management, you can see some of the different types of immune modulators or immune suppressant drug categories. And I don't know if you've seen some of these names, but Pentasa, Asacol, and steroids like prednisone, again, IV steroid would be solumedrol, or methylprednisone is the generic. Again, really important to remember back to endocrine, all of your side effects of steroids. I mean, our goal is to help to cause immunosuppression to treat the illness. But we also need to know that then the adverse or the bad side effect of that could be higher risk of infection, delayed wound healing, elevated blood sugar, right? Mood changes, their skin is more frail, increased hydrochloric acid, so higher chance of ulcers. So there's other things that are going to be side effects, not good side effects, but we are taking the medication to treat the actual active inflammatory response. There's a lot of other immunomodulators that alter the immune response: Imuran, methotrexate, Remicade. I don't know if you've seen some of these commercials on TV, immunomodulators for bowel disease. You've also seen some of these same immunomodulators for like plaque psoriasis. We'll talk about that with skin conditions. So it's kind of trial and error in talking to people with Crohn's disease. They might be on one drug that works awesome for 2 years, 3 years, 5 years, and then it quits working and they got to try another. So I think it's one of those diseases where it is just a trial and error, and everybody can respond a little bit differently. Surgical management, greater than 50% of patients with inflammatory bowel will require surgery at some point. Greater than 50% of patients with Crohn's disease will have surgery, and about greater than 20% with ulcerative colitis. So more people with Crohn's will have surgery, and many times patients with Crohn's disease, especially if they just have a very widespread diseased bowel, they've had to remove sections of bowel, and pretty soon they've removed all the sections of bowel that they can before they need an actual ostomy. So there's many young people with Crohn's disease that already have ostomies that will need that for life. And yet there's some that I think of my uncle, you know, he's getting here, he's 70 and has had lots of bowel resections but hasn't needed an ostomy yet. But they basically said, you know, you get sick again and it's probably going to be that time. So it's one of those things that, you know, they don't wish for, but I think most physicians are very honest with them up front to let them know that a total colectomy or ileostomy certainly might be possible in their lifetime. Diverticular disease is super common, and so it's something that you're going to want to be able to understand and know. Many patients, as they age, will normally end up with diverticuli and have basically chronic diverticulosis. That means that they have a presence of diverticuli. When they do a colonoscopy, they see these outpouchings, they see these sac-like herniations that extends through a defect in that muscle layer where they have like a weak area. And so they have those sacs, those protrusions, the diverticuli. But some people that have them never ever have a problem. They never have an episode of diverticulitis, which is the acute inflammation and or infection of that diverticulum. So our goal, if we do have diverticulosis, is just to keep things moving through at a good pace so that no food has any time to stop off in those little pockets and form an infection, form an abscess, or form irritation. So that's kind of the nuts and bolts of diverticular disease. So here's a picture of what the diverticuli look like. Again, this would be diverticulosis. The patient has those pouches, and again, people can have those pouches and never have any issues or need any management for them at all. The biggest thing is if we get any food and bacteria that are retained in the diverticuli, then they can become infected. As they become infected, they can become swollen, and they can even actually perforate. And now we have a perforated bowel. So perforated diverticuli is an emergency, and those patients would need emergency surgery to repair that area. And if they've had a ruptured diverticuli, they will need a temporary ostomy. So it's very traumatic. We don't want people to rupture their diverticuli and end up needing a temporary ostomy. Usually they need bowel rest for like anywhere from 3 to 6 months. Now, patients can have a microperforation of a diverticuli also, so I want to mention that. If they have a microperf, they didn't need surgery. They have just a very, very small perforation, and they basically are in the hospital. They monitor them for sepsis and anything like that, and that microperforation just kind of heals itself, and they don't have any problems. So I should also add that the diverticuli can occur anywhere along the GI tract, but the majority occurs in the sigmoid colon. So 90 to 95% is going to be at that distal colon, the sigmoid colon. And so via a sigmoid, a flex sigmoidoscopy or a colonoscopy, they would be able to see the diverticular disease. With the diverticular disease, then, what we want to prevent from happening is that increased pressure in that intestinal lumen. We know that we have that herniation, but we don't want there to be a lot of pressure, food, particles, bacteria, or anything that causes pressure into that area. So low fiber diet typically is one of the causes because if we have a low fiber diet, things aren't moving through as quickly. There's more bowel wall hypertrophy, and there's just more pressure that can develop. So diverticulosis would be what we consider the chronic disease without symptoms. They may have chronic constipation. Again, not everybody with diverticulosis is constipated, but they may have some bouts of constipation that they may notice and as a part of their disease. Otherwise, they really don't have any symptoms. Acute diverticulitis is more so when we're going to see them admitted to the hospital, where they may notice that they've had kind of some periods of constipation and that it cycles to diarrhea, so they kind of go back and forth from the constipation and diarrhea, and they have definitely pain. They have abrupt onset of a very intense crampy-like pain, typically again in that left lower quadrant, because 90 to 95% of the diverticuli are in the sigmoid colon. Again, so they have a lot of pain that they can't sit at home and manage and tolerate. They need to come in, and then they typically need to be NPO, have pain management, IV fluids, etc. Now, if they have ruptured a diverticuli, they're going to look a lot more sick. They're going to have elevated heart rate. They'll have low blood pressure, elevated respiratory rate. Elevated temperature, chills. Now we're looking for signs and symptoms of sepsis, signs and symptoms of septic shock. So they would have a CT scan right away. That CT scan and or abdominal x-ray, they're going to see free air under the diaphragm. Free air is never a good thing. If you see free air on the x-ray, that means that there is a perforation of some organ, because then that free air has risen under the diaphragm, and that's what they are seeing. CT scans, very helpful because we get more of a cross-sectional view so that they can see if there are any pockets or areas of abscess that have developed, so that can be very helpful. The other thing that I want to make sure everybody's clear on is that we would not do any scoping if somebody has an acute inflammatory disease going on. So whether that's acute inflammatory bowel like Crohn's or ulcerative colitis, or diverticular disease where we're thinking they have diverticulitis going on. Hopefully it makes sense that we would not want to put a scope in somebody's bowel if they have an inflamed area, because there's a much higher risk of us going through and perforating that bowel wall if there's already some inflammation happening. So this isn't the time to be diagnosing, but they will do those procedures when their disease is not in its active inflammatory state. Potential complications of diverticular disease. So peritonitis is definitely very serious. This would be typically when we have perforations. So kind of perforation and peritonitis typically go together. Again, with peritonitis, we're looking for signs and symptoms of shock. We're looking for that heart rate that's climbing. Blood pressure is going to be dropping. Temp's going to be going up. Respiratory rate's going to be going up. They will typically complain more of a rigid board-like abdomen, just like a sudden change and more intense pain, and their abdomen is they're very guarded and very rigid, tense abdomen. So those are always very serious signs and symptoms that we would need to report to the doctor right away, because they will need to be evaluated. Abscess formation is certainly a complication. Again, if we have a diverticulum that is infected, that has developed an abscess, and again, we're worried about sepsis happening, so we'll be watching for fever and signs and symptoms of sepsis. If there's an abscess that's forming, that's getting bigger and bigger, we would expect to see the white blood cell count also continue to climb. And so we would know that the white blood cell count plus the signs and symptoms, and then of course on CT they could see that abscess as well. Bleeding, we can have some diverticuli that bleed, so certainly could be watching for that as well. So again, be aware, what do these complications look like? We've kind of just talked about that. And what is your priority as the RN? I mean, if they have perforated, they need emergency surgery. If they have an abscess formation and are going into shock, well, they need treatment via our shock sepsis pathway. So again, IV antibiotics are critical for that, for sepsis and abscess formation, and emergency surgery if they have perforation. And then they'll still need all of the sepsis type prophylaxis as far as antibiotics, etc. So hopefully we can prevent complications in the first place and just manage the diverticular disease. So we will teach them with diverticulosis to be on a high fiber diet that will prevent the complications. By adding high fiber and more residue, that will increase the stool volume, that will increase the amount of peristalsis, so it will the time that it takes to go through the bowel will be lessened. So basically things are going to be going through at a good pace, right? We're going to have a good amount of volume, a good steady transit time. So I always say if we kind of just keep things on trucking through, we don't have any time to stop off and get dislodged in those diverticuli. If things are moving slow, they have a chance to just kind of go on in there and of course form those pockets and pus and abscesses. So we want to just keep things moving with diverticulosis. Now if they have the acute inflammatory condition, diverticulitis, now they're going to be NPO for that first 24 to 48. I mean, it kind of depends on how sick they are, but they'll be NPO, may or may not have NG suction. and do complete bowel rest. Once they are getting better and we've decompressed and they're feeling a little bit better, they've had a day or two of antibiotics, then they will start on a clear liquid diet and then slowly advance to a low residue diet. So I want them to have low fiber and residue during that acute inflammatory phase, because we have acute inflammation, so we really don't want a lot of roughage and bulk going through that area. We want things just to be a little easier, a little mild going on through. So it's really important to explain to your patients the differences, because they're used to being told high fiber, high residue for their diverticular disease. So we need to explain to them that they've just had diverticulitis, so they have acute inflammation. So for the next couple weeks, typically, they will be more on a low residue, low fiber, and then once their symptoms and their infection and inflammation is all down and they're kind of back to their baseline, then they'll go back to their high fiber diet. Also, we will tell them not to intake seeds, so popcorn berries, corn, nuts, those sorts of things. We don't want any of those sorts of things that could pocket into the diverticuli easy. Medications, they'll be on antibiotics, of course, IV or oral. Depending on their situation, they'll need opioid analgesics. Again, typically in the hospital, we'll be giving IV hydromorphone or Dilaudid or IV morphine. Stool softeners are okay, but again, we wouldn't do any laxatives, enemas, or anything into the rectal area, no scoping, if they are in their acute inflammatory state. Also, patients with diverticular disease, you might see them like on a Metamucil or a Fibercon or something like that, and they might just take that every day just to kind of add fiber and keep things regular. So in general, those are some things that we would be looking at as far as priority diet and medication management. Surgery-wise, they may have to have surgery. Again, especially they will for sure have to have surgery if they have a perforation or any abscess formation or obstruction as a result of their diverticular disease. This picture is just showing an example of what's called the Hartman procedure for diverticulitis, where they will make a ostomy, a temporary ostomy, and then after, again, depending 3 to 6 months or so, the second phase will be a colostomy takedown, and they'll hook everything back up, and the patient will be able to resume their bowel movements as normal. So the answer here is 3. Hemorrhoids could indicate chronic constipation, and that is a strong risk factor for diverticulosis. Constipation increases the intraluminal pressure in the sigmoid colon, and that leads to the weakness in the lining and the diverticuli forming in the first place. Correct answer here is 3. We would expect the patient, it says which would you, the nurse, question. We would question a clear liquid diet because they would be NPO. They need to have strict bowel rest and IV antibiotics once they are hospitalized for acute diverticulitis. Irritable bowel syndrome is a non-inflammatory condition, so not to be confused with Crohn's and ulcerative colitis, which are inflammatory conditions. Another word you might hear called is spastic bowel. It is one of the most common GI problems, about 12% incidence, and definitely one of the leading causes of workplace absenteeism. So again, for some people associated with their food intake, and they may have irritating foods, alcohol, smoking, fatty diet, also can have more of a genetic predisposition and or precipitated by stress and anxiety. This is greater in women than men. And basically, it's just a spastic contraction of the bowel that affects the intensity by which peristalsis will propel the fecal matter forward. So again, no inflammation, more an intestinal mobility and spastic contraction type etiology or pathophysiology. So here you can see the spastic contractions of the colon in this picture, and I think you can easily see how there would be pain and kind of more of a colicky pain, and also typically bowel motility changes where it will increase or decrease transit time depending on the spasticity, so sort of fluctuating usually between diarrhea and constipation. Symptoms of irritable bowel are as follows. You can see the alteration in bowel pattern that we just talked about. That's the primary symptom where they'll have more urgency with diarrhea and then also have periods of constipation. A lot of bloating and abdominal distension or gas and flatulence. Again, the pain is typically more intermittent and colicky. And then sometimes the abdominal pain is preceded by eating and often relieved by defecation. Management of irritable bowel really depends on the person and the severity of their irritable bowel syndrome. Pain management, controlling diarrhea and constipation. So some persons may need to be like on a Metamucil or a Fibercon, like a bulk forming, to kind of keep the transit time more regular. That can help with a spastic colon. Or again, if they are having periods of diarrhea, Imodium or Lomotil, those anti-diarrheal agents. Again, just the healthy living as far as reduction of stress, getting some exercise, not smoking, alcohol, minimal with that, and then also just having a healthy diet, higher fiber diet, again to help with just the normal transit time, and then decreasing fluid with meals can be helpful also so that things don't go through so quickly. Appendicitis is one of the most common causes of acute abdominal pain. It is the most common reason for emergency surgery in the United States. You can see kind of the age prevalence and males greater than females. The appendix, as you remember from the first pictures of A and P, is a small appendage on the cecum, so just below the ileocecal valve, and that is right before you start the large bowel. So the appendix, we don't need it. So thankfully, if somebody is having appendicitis, they can just take it out. But what happens is there's inflammation and pressure that makes that appendix edematous, and then it is at risk, though, still for developing an abscess or getting pus or infected if it's not taken out in a timely fashion. And then you also can have a ruptured appendix, which leads to a little more problem as far as increased length of stay in the hospital, a longer IV antibiotic to make sure that an abscess doesn't form. Signs of appendicitis are typically very classic. They don't look like a lot of other abdominal type conditions, so many times it can be easier to diagnose appendicitis than some other things. Just a real severe sudden onset of that right lower quadrant pain, and it does not go away. Patients will say it started during the night and they couldn't sleep, and they just by morning even already they knew they couldn't take it. So it seems like it's a very severe pain that patients will report. They just knocks them down, they can only be in a fetal position, and so it really presents itself as very significant and different than just a usual sort of stomach ache, if you will. If they are developing more of a what they call hot appendix, where it's really getting inflamed and possibly has ruptured or getting ready to rupture, they may develop a low-grade fever as well and get more tachycardic. Now, associated nausea, vomiting, anorexia is very, very common with appendicitis as well. They also will have typically local tenderness at McBurney's point. Again, in over 50% of the cases, they'll have that tenderness between the right umbilicus and the anterior superior iliac spine. So we're looking for that, feeling for that. They also will have rebound tenderness and what's called the Rosing's sign. This is pain felt in the right lower quadrant after they palpate the left lower quadrant. So they'll push on the left lower quadrant and that pain will refer over to the right lower quadrant. So several things that they'll do. They can also do the jump test, and they can have patients kind of jump up and down a little bit, and it is very, very painful in that right lower quadrant. Patients aren't even really able to do it very well, and that's something that they can also assess for. So there's lots of pain type things that are very clearly that. Ultimately, they'll do a CT scan or an ultrasound to see if the appendix is distended. So here you can see the McBurney's point, which is basically that right lower quadrant. And then remember the Rosing sign is where they palpate the left lower quadrant, and it refers to the right. This would be some expected labs for somebody with appendicitis, and this patient actually had a ruptured appendix. White blood cells 13.5, so high but not terribly high. But what you'll also notice, remember, is the neutrophils, and those are at 87%, and the lymphocytes then go down. Remember, the neutrophils are 50 to 70% of all of the white blood cell types on the differential. So if they go up, the lymphocytes have to go down because between the neutrophils and the lymphocytes, that's the main percentage of all of the 100% of white blood cells. So neutrophils go up. Remember, those are the first acting white blood cells to go to the site. They are basically like soldiers with guns. They're going to go immediately. They're going to fight. They're going to do their job and try to help to clean up debris and help prevent residual infection for being in there. Try to clean everything up. So for labs, we would expect the total white blood cell count to be up. We would expect that increased percentage of neutrophils. The CT scan they will do to see what size that appendix is, typically greater than 6 centimeters. They'll have margins of what they feel should be operated on, but typically they're not going to mess around with that. We will keep the patient NPO because they're likely going to have surgery. Again, they may prefer the fetal position just to kind of have their knees more up to their chest area. IV fluids, antibiotics, of course, IV pain management. They might need antiemetics as well. Again, decrease anxiety and just do the teaching that's necessary to get them ready for surgery. Ultimately, the complication would be perforation, and we want to make sure that we get them in and evaluated and to surgery before they would perforate. So increased risk of perforation basically within the first 24 hours after onset of pain. So we don't want people sitting at home with a severe abdominal pain and then to come in 2 days later to find a really sick patient with a ruptured appendix and septic. So they should come in and get evaluated and hopefully get surgery taken care of right away in the first 24 hours. Again, if they have perforated, they'll typically put in a Jackson Pratt drain, a bulb syringe drain, so that they can drain out all of the rest of that area so that no pockets form. And obviously they've cleaned it out good in surgery and flushed it with antibiotics, but they'll want to place that drain typically. Peritonitis, we've talked about a few times, so just have a couple more slides just to make sure everybody understands that this would be an emergency. This is a serious complication where we have inflammation of the peritoneum, and this is the membrane that lines our abdominal cavity. So it's usually a result of bacterial infection or a perforated ulcer, perforated bowel, or perforated diverticuli. Could be perforated appendicitis. Certainly could have peritonitis and have a perforation of one of the organs due to external trauma. Now, we just had a young gal with a serious car accident that had a perforated bowel because of the trauma of the accident. So there are different reasons for the perforations, but this is something that the patient's going to get really septic and really sick pretty quickly. So again, if we think of our bowels do normally have bacteria as part of the normal flora. So once they rupture, we're getting all of that bacteria into the peritoneum where it's not supposed to be. This picture shows the common GI causes of peritonitis. So again, we can have ruptured ulcers, gastric or duodenal, the inflammatory bowel disease, Crohn's disease, or ulcerative colitis. Again, the diverticuli, and then appendicitis. So those are the most common areas where we might have a perforation. So remember, with peritonitis, it is very important to assess for abdominal wall rigidity. It's a classic finding for peritonitis and sometimes is referred to as a board-like abdomen. So we want to be assessing for that. We also want to be assessing our patients for a high fever. We want to definitely be assessing for tachycardia and decreasing circulating blood volume or decreased blood pressure. We're going to expect that urine output to be dropping as well. As the patient is going into septic shock, we're seeing that decrease in blood pressure, that increase in heart rate, that narrowed pulse pressure, the fever, and again, that rigid board-like abdomen, which is very, very classic and very specific for a peritonitis. So we always will report that immediately when we see that. Typically, they'll have abdominal pain, and it may be referred. It may be more localized, definitely more have a tender, distended kind of muscle rigidity and board-like abdomen. As far as treatment, fluid replacement is going to be very, very important. Again, remember, this patient is in septic shock, so we have to replace fluids. We may need to replace other electrolytes depending. They're going to need massive antibiotic therapy, large dose, broad spectrum antibiotics. These would be the patients that would likely be on like a vancomycin as well, possibly. And again, depending on, obviously, if it's a perforation, they need surgery for that. If it's an abscess that is formed after another surgical complication or after they even maybe have repaired a perforation, but now we're still having an abscess, we would possibly need to have that abscess drained. They usually do that CT guided in radiology, and or they might actually take them back to surgery to actually open them up again and clean it all out where they can see firsthand and visually see everything. So again, ultimately we got to remove that infected material, which is the cause of the peritonitis, and so it will really depend on the size and location and kind of clinical picture for each patient, whether they're going to try a CT guided and a drain first and antibiotics, or whether they're not going to mess around and just take them back to surgery. This Creative Memories notebook is really good, talking about the hot belly or the peritonitis. The only thing I want to note here is that they have increased pulse and increased blood pressure. I mean, initially, with a lot of pain, their blood pressure might be up, but as soon as they're going into shock, that blood pressure is going to drop. As soon as they have blood volume that's dropping, and again, they get into this septic shock. So I didn't want that to be confusing, so I just wanted to make note that they're referring to somebody as having excruciating pain initially, but as soon as we get into more of the shock-like symptoms, you know that that blood pressure is going to be down. Colorectal cancer is the third most common cancer. So if we look at cancers by incidence, breast and prostate is number 1, and then lung and bronchus is number 2 as far as how frequently it occurs, and colorectal is number 3. Now, as far as cancer death, number 1 is lung, number 2 is colorectal, and number 3 is breast prostate. So colorectal cancer, along with lung, bronchus, breast, prostate, are cancers that, of course, they're the top 3 for incidence and the top 3 for cancer deaths as well. So we do need to know it. We're going to see it more often than other forms of cancer. So again, colorectal is the third most common by incidence and by number of cases, and it's the second most common as far as cancer deaths, number of cancer deaths. So increased age, of course, is a risk factor. 90% of the cases are patients over the age of 50. Equal by gender definitely is significant if you have family history of a direct first-degree relative. You'll see some of the other sorts of risk factors, previous colon cancer. I would add even history of polyps increases their risks, even if they were non-cancerous polyps on other colonoscopies. Low fiber, again, if we have low fiber and we have slowed transit time and not passing stools in more of a regular fashion, that increases the risk of cancer as well. And you'll see increased risk with tobacco and alcohol use also. So manifestations, signs, and symptoms really depends on the stage and location, but the number one reported is just a change in bowel habits, maybe fluctuating constipation, diarrhea, against things that aren't necessarily super noticeable if we lead busy lifestyles and we're not necessarily paying attention to all of that in great detail. Blood in the stool is definitely a later sign, as is anemia, anorexia, weight loss, and unexplained fatigue. So again, hopefully we're not waiting for those signs and symptoms to happen to get our initial diagnoses, but sometimes that does occur. And then the CEA, again, just a reminder, this isn't a reliable indicator for diagnoses, but it definitely can help with the prognosis. So this picture just shows the different sites for colorectal cancer, and in particular I just want to point out that you can see a large percentage, about 61% of colon cancers are identified in the sigmoid colon and lower. So between the sigmoid and rectum area, that's where the majority of the cancers are. So that's where the cancer screening recommendations come from. Every 5 years a flex sig, and then every 10 years a full colonoscopy, which would visualize all areas that you're seeing in this picture. Otherwise, the sigmoidoscopy will just go up to about where the descending colon wording is on this picture, and then down through the sigmoid colon and rectum. So surgical diversions, colostomy and ileostomy. Colostomy, again, they're both fecal diversions. Basically, they get their name based on where the actual portion of the colon, where they're forming that diversion. So colostomy will either be where they will have the diversion in the ascending part, the transverse, or the descending, or the sigmoid. And ileostomy is where the whole large intestine is completely removed and that diversion is created at the ileum. So it's really important if a patient has an ileostomy to know that that's correct and accurate in what we're saying, because if they have an ileostomy, that means that their whole large bowel is removed. And the big thing with the ileostomy, if all of the large bowel is removed, and the large intestine we know is responsible for water reabsorption, with all of that gone, they will always have liquid stools. And so that's really, really important to know, like, your patient's individual ostomy, like what you're expecting for their stool consistency to be, and that really does depend on where, which portion of the colon was removed and where that stoma was placed. So this picture just shows some of the different, which sections of the bowel would be removed. So like the bottom one is the rectal sigmoid resection. So they've removed all of that shaded kind of peach color. That's what was removed. And again, on the next slide, we'll talk about what we would expect for the stool consistency to be based on how much is removed. So let's look at these pictures. If we start with the bottom right, the sigmoid colostomy, if they have the sigmoid colostomy and they have that portion in purple removed and the stoma formed where we see the stoma, what would we expect their bowel movements to be? Well, we have basically the entire large bowel to absorb water, so we would expect their bowel movements to be basically formed, almost as close to normal as what it would be coming out the rectum. To the left of that, then we have the descending colostomy. Again, we have all of that shaded purple that has been removed. It's a little bit higher up, but again, we would expect it to be, semi-formed in that area because we have a lot of the large intestine still intact to be able to reabsorb the water. Now, if we go up to the very top left and we have the ascending colon, almost all of the large bowel is removed. And again, a lot of area for water reabsorption is gone as more of that large intestine is removed. So we would expect mostly fluid stools at this time. If you were writing a care plan for somebody with a new ostomy, and even with an old ostomy, it kind of depends on how long they've had it and how they're doing, disturbed body image would absolutely be pertinent. We want to encourage expression of feelings. We want to help them get connected with support groups. This can be a very challenging thing, as you can imagine, if this is something that you have to live with and adapt to for the rest of your life. And again, definitely a body image thing if you think of bathing suits and vacation medications and things like that. If we're dressing for cold weather and are more covered, a lot easier to hide and all of that, but you have to think about, you want to take your t-shirt off or wear a swimsuit. That sometimes that can be really challenging for those patients. Otherwise, a lot of knowledge deficit, a lot of teaching. There is so much to learn about the ostomy cares, the cleaning, the bag changes, and the pouches, and all of that. So it is really a learning curve that we support them through in the hospital, but they need lots more support once they go home themselves, as well as their family members who may be helping with the process. Again, it does affect the whole family. It may impact their social status and what they feel comfortable doing. You talk to a lot of patients and they're just always worried about having an accident with their bag when they're out in public. So I guess, although we can't totally relate if we don't have one, I can definitely see where that would be very, very applicable. As far as risk for complications of electrolyte imbalances, they'll definitely be on an Acrid INO. We'll be doing daily weights. Again, remember to look at electrolytes. Again, if we're losing a lot of GI secretions, we're losing a lot of potassium typically. So that's something, not only looking and thinking about hypovolemia, but also thinking of hypokalemia as well. While not every student may have taken care of a patient to date with an ostomy, this is something that it does just kind of take some practice in getting used to how to do the bag changes, how to make sure to get the right fit. Obviously, assessing the stoma is very important, making sure it's a beefy red color, making sure it's not pale or dusky or purple. Those would all be abnormal, showing decreased circulation. Again, assessing the surrounding tissue and skin. We want to make sure we have a tight fit of the appliance and barrier cream so that we don't have stool going on the skin and that acidity with that. And it would be the same if they have a urine diversion. We don't want the acidity of the urine going on the skin either. So there's lots of great products, skin barrier creams. Definitely as the nurse, it's our responsibility to be emptying that. Don't wait for it to get full, a third to a half full at most. And if it's mostly liquid stool, like an ileostomy or the ascending colostomy, it gets heavy really fast. That liquid gets real heavy, so we got to be emptying even at a third full there. Otherwise, it's going to pull away. The appliance will pull away, and then you'll have leaking and need to do a full appliance change. So we got to be proactive with that and teach our patients to be proactive with that as well. As far as ostomy cares, we'll do all of the education, again, related to sizing, cutting out the new patterns for your new appliances, how to empty it, how to make sure that it's sealed tightly, etc. Also things like odor control and nutrition and foods that can be a little bit more irritating or foods that can be more odorous. All of those things are important to note. And then we will have the wound care nurse, the enterostomal therapy nurse, also consulting to help with a lot of that teaching. So between our specialists that are helping us and the RNs themselves, we get a lot accomplished with our patients as far as teaching while they're in the hospital. This slide is more for reference, not that you necessarily have to memorize it, but again, a lot of patients are concerned about odor control and which foods would be more gas producing, which ones produce more odor, so we usually give them that list of medications. We have a nice little pamphlet form that has a lot of this in it. This also would be more of a reference slide for education for our patients, a list of high fiber foods that may cause blockages. So we certainly don't want to get blockages of the ostomy, no different that we wouldn't want to get impactions of the rectal area. So it's really important to give them some of these resources so that they can kind of minimize some of these foods that could cause them problems. I just have this picture of the actual clamp. Again, really important that you actually wrap the end of the bag kind of twice folded. It's kind of hard to explain just verbally around this clamp and then close it. And then also really important to pull back on the clamp to kind of test that it's actually locked so that you actually got it closed after emptying. So we'll teach kind of patients the tricks of the trade with regard to using their clamps and making sure that it's closed completely too. This picture is just showing some of the appliances. There's one-part appliances, two-part appliances, all sorts of ever-changing and developing products. So again, ostomy cares is something like with wound care that we just have to stay up to date on, and hopefully your facilities, educate you on the new products as they're coming out. Things to consider with our older patients for geriatric clients with ostomies is to just realize that their skin is even thinner, going to be more easily irritated, more easily have a breakdown. So we want to pay special attention to skin cleansing and proper fit of the appliance. These patients will have delayed healing time, so it might take them a longer time to heal after a major surgery such as this. They ordinarily have delayed elimination, and even then, after you've had a major surgery like this, it takes a while for your bowels to start working as normal as the new normal would be. So we just have to allow extra time for this elimination pattern to sort of regulate for them. And then certainly fine motor skills, coordination, the manual dexterity needed for doing the cares themselves, for getting the clamps on and the appliances, and even the visual acuity. I mean, this is pretty complicated for a lot of our older patients. So they may not, even with an elderly spouse, be able to do it on their own. They may need home care to come in to help with that, or family members that are able to help with the actual big changes. But either way, if they're living home independently, they'll need to at least be able to have a means of emptying it themselves. So again, we'll work with them, and we want them to do it while we're watching them to see exactly how they're doing and what they're doing well and or what they're struggling with. So the end of the PowerPoint here is just going through a few conditions that don't necessarily fit in other areas. So I just kind of tacked them on the end here. Hirschsprung's disease, also known as congenital aganglionic or megacolon. They basically have absent ganglionic cells in the rectum and large colon. They'll typically notice this at birth when they don't pass the meconium stool within that first 24 hours. They typically have abdominal pain, distension, nausea, vomiting, might be vomiting up bile-stained vomitus. Again, normally they will recognize this already right away in infants. If not when they're first born, certainly at a younger age. They'll have chronic constipation, so assessing for foul smelling and ribbon-like or pellet-like stools. That's very classic for Hirschsprung's disease, and we would really want to question that and have them be evaluated. Again, it's typically more a younger aged diagnoses, so we'll be watching for poor feeding, abdominal distension and pain, like I said, and then FTT, failure to thrive types of symptoms, not gaining weight, etc. We'll maintain a low fiber diet, high calorie, high protein, and again, depending on the patient's situation, they may need to have surgical intervention for this. Celiac disease or gluten-sensitive enteropathy is basically the inability to digest gluten, which is a protein found in wheat and wheat-based products. So it's an autoimmune. There's this accumulation of the transglutamine, which is toxic to the intestines. We have all of these little villi, like finger-like projections in our intestinal tract, and they become chronically inflamed and basically causes that malabsorption. So sometimes patients might have the GI type symptoms of celiac, more so the diarrhea, constipation, abdominal pain, bloating, etc. More fat in the stool, so more where you might have that oil and water type look where you have that tells us that there is more fat. Bulkier stools is also one of the signs and symptoms that you'll see on there for gluten sensitivities. But again, there's a lot of atypical symptoms, so not everybody has like the diarrhea symptoms or malabsorption, weight loss, etc. Some patients with their malabsorption just have iron deficiency, muscle wasting, can have migraines, osteoporosis, joint pain, and a lot of common association with lactose intolerance with gluten sensitivity as well. So gluten celiac does have kind of a wide variety of signs and symptoms, and it's not always diagnosed just based on the sensitivity that you might expect to produce diarrhea, anorexia, abdominal pain, and bloating. So with somebody with gluten, the nice gluten sensitivity, the biggest thing is going to be that gluten-free diet that's going to help heal the villi and get their intestinal tract absorbing again. Although it may take even 6 to 12 months to really get the GI tract back on track, they see even after 2 to 3 months after strict gluten-free, that patient should be at least moving towards starting to absorb, but it definitely can take a longer time, even up to a year or more, to actually really get full absorption back. So if they're being treated for iron deficiency anemia, typically, again, if you just started iron supplements and you don't know that you have celiac, you're not going to absorb it. So that's also sometimes where they will do further testing if somebody has iron deficiency anemia, for example, with an unknown cause or etiology, that they might check for celiac disease. Lactose intolerance is where we have a deficiency, lactase deficiency, so it basically produces the inability to break down lactase, which is the sugar found in dairy. You can see the causes there listed in that second bullet. Typically, patients will have more diarrhea, abdominal distension, cramping and pain, and increased stool mass and more gas and things after they've had lactose, if they're having the lactose intolerance. So again, there's lots of lactose-free or a lactose-restricted diet that would be recommended, and lots of lactose-free products now, way more than ever used to be. Same with the gluten availability of things to purchase, so it's easier to do the dietary recommendations for both lactose intolerance and gluten-free for celiac than it used to be. So with pyloric stenosis, we think about hypertrophy of the muscles of the pylorus, and that causes a narrowing of that canal between the stomach and the duodenum. If you think of a narrowing or stenosis in that area, hopefully you can think of there would be high pressure kind of behind where that narrowing is, which would be producing significant projectile vomiting when the patient gets ill. So projectile vomiting is very classic for pyloric stenosis. There's so much pressure that pushes through that narrowed opening that it just comes out very forcefully than other forms of vomiting. So they may be able to palpate an olive-shaped mass in the right upper quadrant. Again, may be able to see some of that that movement in the abdominal wall. Again, it's typically in infants, so they don't have a lot of subcutaneous, so we can see kind of those motions of the abdomen, those wave-like patterns. These infants will definitely be irritable, and they're very hungry and colicky even after they've eaten, so this would be a sign that maybe something's going on. And again, the projectile vomiting is so much different. It's not like they just, coughed up or regurgitated a little bit of formula. I mean, they have some serious strong projectile vomiting that's shooting a long ways across the room even, so it doesn't really look a lot like other sorts of conditions. Of course, we're very worried about dehydration, malnutrition. Again, if we're losing a lot of acid stomach contents with the projectile vomiting, we would expect alkalosis for the problem, metabolic alkalosis. So eyes and nose, daily weights, watching those electrolytes are very, very important for these infants that typically that's the age that we know right away are going to be diagnosed with this pyloric stenosis. So they may need a pylor myotomy. They're going to need to repair that. They're going to need to make an incision and kind of loosen that area around the pylorus, and that's typically done via a laparoscope. So it's a laparoscopic procedure which helps for healing time, less risk of infection, etc. So this slide just has a lot of good information on summary regarding cleft lip and palate. Again, this is a congenital defect where we have a result of failure of the soft tissue or bony structure to fuse during the embryonic development. So we have openings in the lip and the palate. With this, there is going to be several surgeries that are going to be done at different times. So again, if we think of infants and parents and bonding and just the stress of multiple surgeries even by age 1 or 2, we want to make sure we're allowing for that ventilation of feelings, psychosocial support, etc. That can be very stressful. For the infants themselves, if we think of an infant that's had surgery and we have incision to protect, they typically will need soft elbow restraints to protect that incision, and or parents that are need to be holding them to make sure that they are not just reflexively grabbing towards their mouth, lip, face area. Lip protection, there's metal appliance or adhesive strip type shields that can be taped to the cheeks that kind of help with that lip protection as well. So between soft elbow restraints or other forms of devices for lip protection, that will be a pretty big priority to make sure that we keep that incision site safe, secure, and free of touching to reduce risk of infection as well. Patients with cleft lip and palate, as you can imagine, they've had these openings. There may be a potential for speech development. Many times they've had frequent hearing infections, ear infections, and may have some residual hearing loss that can affect their speech development. So they'll be evaluated for all of those things. And then lastly, of course, very important for nutrition management, they will have definitely a specific feeding protocol, specialized feeding techniques that we're teaching parents. They will use more of what like the preemie nipples, so they don't have to work hard, so that it can just drop in their mouth more easily. Of course, because they do initially before repair have difficulty with swallowing, sucking, etc. We'll definitely want to hold the infants in an upright position and do more burping than normal and just more regular assessments to make sure that they're not aspirating. So bulb syringes are definitely kept at the bedside for safety.